So ayun, magandang hapon po sa ating lahat at confused na naman ako. Share screen. Share screen. Yun. Ito po ang ating panghapon na program. So this morning po, recap lang ng konti, we focus on healthy aging in Down syndrome with a heart-to-heart interview with Ms. Samantha Goles, a person with Down syndrome. So Dr. Alexis Reyes handled that section of the program and nakafocus siya sa conditions or ng mga persons with Down syndrome kasi hindi lang Down syndrome condition pagkabata but it's something we have to deal with for our entire lives. Now, after that, Teacher Herc Parajang from CBM, who is a parent of a young lady with Down syndrome, ay shinare naman yung experience niya bilang parents. Ngayong hapon po, it's 1:35, we shall be beginning. So ito po yung program natin and I shall be turning you over to Ma'am Kai, the MC from Health Learning Center. Magandang hapon po sa ating lahat. Welcome back po sa ating webinar. Sana po makahabol yung iba. So good afternoon everyone. Teacher Kai, take it away.
So good afternoon po. Welcome back po sa ating mga participant and panelists. So for our first speaker for this afternoon, she is a pediatric endocrinologist and a metabolic physician, a clinical professor of pediatrics at University of the Philippines, Manila College of Medicine, where she is the division chief and training officer of the pediatric endocrinology. She is also a research professor at the National Institute of Health Manila and has research publications in local and international journals. She obtained her medical degree from the University of the Philippines, Manila College of Medicine after her pediatric residency at UP-PGH. She completed 2 fellowship programs. First is the Pediatric Endocrinology and Metabolism at the Philippine General Hospital and Biochemical Genetics at the University of California, San Diego, USA. Also, our speaker for this afternoon is the National Coordinator for Short-Term Follow-Up and Chair of the Experts Committee for Endocrine Disorders of the Philippine Newborn Screening Program. Let us all welcome Dr. Sylvia Capistrano Estrada.
Thank you for your kind introduction and congratulations to the organizing committee. All right, for allowing me to join this very laudable program of yours. So, maraming salamat po, no? And I feel honored that you have allowed me to talk about endocrine health. So, siguro tatanong niyo, bakit ba kailangan natin why should we actually talk about that? Hindi yata nag-move. Okay. So, this is going to be the outline of my talk this afternoon. And sana naman, pag may question kayo, ilagay nyo lang sa chat box. I tried to make my lecture short para po may mga time tayo mag-discuss ng questions. No? So, ito yung outline natin. Titingnan natin ano ba yung mga endocrine conditions sa mga Down syndrome, ano yung mga disorders doon, tapos ano yung guidelines para sa health sa mga persons na may Down syndrome. And then finally, bibigay ako ng konting summary po. So, as I said, why talk about endocrine health in persons with Down syndrome? First of all, kasi mas madalas nangyayari yung endocrine disorders sa Down syndrome kesa sa general population. Yun ang isa. Pangalawa, mas marami na tayong mga diagnostics ngayon at saka treatment para mabigyan natin ng lunas ang mga kondisyones na ito. Pangatlo, kung mas maaga natin na-detekto, early intervention, mas mabibigyan natin ng pagkakataon na mas maganda ang outcome para sa ating mga pasyente at saka sa mga bata nating may kondisyon na endocrine. Finally, kapag healthy yung Down syndrome patient natin na bata, inaasahan natin na healthy din sila pag naging adult. Alalahanin nyo, ang lifespan ngayon ng children, ng persons with Down syndrome, pareho na rin po ng lifespan ng regular general population na hindi affected with Down syndrome. Okay? So, nung tinitingnan ko, ano ba talaga yung pinakamadalas na health condition sa mga adults na may Down syndrome? Base dito sa isang publication sa American Academy of Family Physicians, ang nakikita nila itong lahat, no? Pero Pasensya na po mali. Pero makikita po ninyo yung top talaga yung endocrine, no? Tapos, dun sa endocrine, dalawa po ang pinakamadalas na nangyayari, yung thyroid diseases at saka diabetes. Pangalawa yung mental health, kaya maayos, mabuti naman. Parang pinag-usapan nyo yata kanina ni Dr. Reyes, no? So, ito yung mga tatalakayin natin this afternoon. Ito yung mga scope ng endocrine disorders na nangyayari sa mga Down syndrome, no? Meron silang thyroid dysfunction, may mga growth issues sila, meron silang meron silang risk for type 1, kuminsan din type 2 diabetes. May issues din po sila sa fertility, wala sa puberty. Tapos po yung kanilang buto medyo po may problema po sa mass, no? Parang may risk po sila magkaroon ng osteoporosis in the future. So, ito yung mga thyroid condition, pinakamadalas mangyari, yung tinatawag natin na subclinical hypothyroidism. Tapos meron din nangyayari na congenital hypothyroidism at saka autoimmune thyroid disease. Isa-isahin natin to mamaya, no? Yung pang-apat, makikita nyo, yung linagay ko lang po siya sa parenthesis kasi hindi naman po siya talaga kondisyon. Kundi, kuminsan nagkakaroon kami ng referral dahil nga akala nung mga doktor o ng nanay o tatay na baka may thyroid disorder na yung kanilang anak dahil nga po yung TSH parating mataas. O i-discuss ko yan mamaya. Na? So bago natin talakayin yung mga disorders, i-review muna natin. Kasi baka mamaya sabi mo anong pinag-uusapan ni doktora, ano ba yan? O sige, yung thyroid gland natin, tatay may thyroid gland dapat, no? Nandito siya sa ating leeg, nandito sa loob, no? Ngayon, yung function niya, ito ay under the control of the brain. So, dalawang parts sa brain na nagko-control sa thyroid function. Yung hypothalamus, ang kanyang mediator, yung tinatawag na TRH or thyrotropin. And then yung pituitary gland naman, yung kanyang mediator, yung thyroid stimulating hormone o TSH. Kung ang hypothalamus, kukulitin niya si pituitary, gumawa ka ng TSH, si pituitary magre-release ng TSH at yung TSH kukulitin naman niya o isi-signal niya yung thyroid gland para gumawa ng thyroid hormones T3 and T4. Ngayon, kapag sapat na ang thyroid hormone level sa katawan natin, magbibigay yan ng senyas sa pituitary gland at saka sa hypothalamus para sabihin, sapat na kami, wag mo na kami kulitin. So in other words, pag normal ang thyroid hormone levels natin, pati yung TSH natin at saka TRH normal din. Pero for example, hindi maayos ang function ng thyroid gland natin. So pwedeng mababa ang kanyang output. So ngayon magsisignal na ulit yan sa utak. Konti lang kami. So ang signal na mangyayari is ang TRH at TSH tataas yan para magbibigay ulit ng senya sa thyroid glands. Gumawa ka pa kasi kulang. So high TSH, low T4, hypothyroidism. On the other hand, kapag naman medyo sa halimbawa, hyper itong gland natin, may nodule o may sakit siya, nagproproduce siya sobra-sobra, dami-dami. So magpapadala ulit yan ng senya sa utak. So sasabihin, marami na kami. So ang mangyayari, yung TSH at TRH mababa. So pag mababa yung TSH, mataas yung FT3 and FT4, ibig sabihin, hyper ka. Okay? So, yung tatlo, hypothalamus, pituitary, thyroid, sila yung nag-monitor, sila yung nagko-control ng ating thyroid hormone metabolism. And yung thyroid hormone naman, kailangan sa iba't ibang parte ng katawan natin. Heart, brain, lungs, even everything else. Okay? So, punta tayo dun sa subclinical hypothyroidism kasi di ba sabi ko, yun ang pinakamadalas na nangyayari. May mga iba't ibang pangalan niya. Makikita mo, mild hypothyroidism, compensated hypothyroidism, isolated thyrotropinemia. Pero pag tinignan mo yung bata o yung adult, wala siyang sintomas. Walks lang siya. Tapos, pero biochemically, sinabi nila, meron kang subclinical hypothyroidism kapag ang TSH level mo nakakahigit sa 5. Kasi ang normal usually between 0.5 until mga 3 point something lang. So pag 5 na, medyo mag-iisip-isip ka na, baka meron nang nag-uumpisang hypothyroidism. Pero pag kinuha mo yung levels ng thyroid hormones, maayos siya, normal. So, usually, nade-detect to sa newborn screening o kaya pag nagpagawa ka ng blood test, nakikita yon. Kaya tuloy, mag-iisip yung doktor o mag-iisip yung pamilya, ano kaya ang ibig sabihin nito? Okay? Gaano kadalas naman itong subclinical hypothyroidism? Ito po ay nangyayari as often as least amount of 7% to 40% of the population. Pero mas madalas between 25 and 30%. Sorry, ito ay mga incidences from the United States and from Europe. Wala pa po tayo dito sa Pilipinas. So siguro dapat mag-umpisa na tayo mag-kolekta ng data sa ating population of Down syndrome, no? So, so medyo madalas po siya, no? So ngayon, hindi nila alam kung bakit nangyayari ito. Meron silang mga hypothesis, baka daw may mga antibodies, pero hanggang ngayon, hindi pa rin nila alam kung ano talaga yung role, kung bakit nagkakaroon ng ganito. So pag kumuha ka ng picture, yung tinatawag na thyroid scan o thyroid ultrasound, makikita nyo, nandiyan naman yung thyroid gland niya, maayos naman kung tingnan, normal naman siya. Yung size at saka yung function. So, magtataka ka bakit, di ba? Tapos, pero yung iba, may mga konting mga tao na may Down syndrome na pag kinuha mo yun, may subclinical hypothyroidism, pero meron silang malaking gland, yan ang ibig sabihin ng goiter, o kaya maliit, hypoplasia. Ibig sabihin, hindi maayos ang structure. Rarely, nasa maling lugar o kaya wala. Pero hindi pa rin nila alam kung saan mapupunta itong subclinical hypothyroidism. Ano ang mangyayari sa kanya? Hindi siya consistent. Pupunta ba talaga siya hypo talaga o okay lang? So hindi talaga nila alam. So ang naging next question is, dapat ba natin gamutin? Di ba? Kasi worried tayo pag hindi natin ginamot, baka makakadagdag doon sa mental deficiency or the mental dysfunction of our children, whether Down syndrome or not. Di ba? So anyway, anong ebidensya? Sa ngayon, ang nakikita nila, kahit magbigay ka ng treatment, wala pa silang nakikitang positibo na impact sa maayos na paglaki at saka development. Number 2, nakikita rin nila na wala talagang clear evidence na pag binigay mo siya ng maaga, makakatulong. Pangatlo, mild lang naman yung kataasan ng TSH, so sabi nila, most likely transient. However, may mga ibang nagbibigay ng payo na kapag talagang overt hypothyroidism, anong ibig sabihin nun? May mga senyas o kaya yung bata, yung TSH niya super high, above 10, tapos yung FT4, FT3 niya mababa na sa normal. So yun, dapat i-treat niyo na. Huwag na kayo maghintay. Pangalawa, lumalaki yung thyroid gland. Ang pangit naman yun, di ba? Pangatlo, may mga antibodies na nagdetekto sa dugo. At pang-apat, kapag mataas yung TSH, doble na doon sa kanilang sinasabing subclinical na 5 lang. Okay? So, punta naman tayo sa congenital hypothyroidism. Nangyayari din ito sa Down syndrome. In fact, kung ihahambing mo yung Down syndrome, mas madalas mangyari ang hypothyroidism sa kanila kaysa sa regular population. Di ba nag-newborn screening tayo ngayon? Yung pangkaraniwan na newborn na hindi Down syndrome, ang frequency ng pagdating ng hypothyroidism sa kanya, 1 in every 2,000 or 1 in every 3,000 babies. Tapos mas madalas nangyayari sa babae kaysa sa lalaki. Sa Down syndrome, 1 in every 100 to 140 babies na Down syndrome, meron silang congenital hypothyroidism. Tapos, pareho lang. Males and females, pareho lang silang incidents, no? Ngayon, ano daw ang sanhi ng hypothyroidism sa Down syndrome, yung congenital? Number 1, yung pinaka-common talaga, hindi maayos yung thyroid gland mismo nung ginagawa ang thyroid gland nung nasa womb pa si baby, hindi maayos yung structure niya. Kaya hypoplasia. Hypo means low. Okay? Tapos yung iba naman, meron din walang nakikita. Mukhang normal. So baka enzymatic, no? And then rarely, yun nga, nasa maling lugar yung thyroid o kaya walang thyroid gland. So dapat ba natin gamutin? Ay ba, syempre. Gagamutin natin yan. Kasi alam mo, ang thyroid hormone, important yan for brain development, especially in the first 5 years. More so, first 2 years of life. In fact, you must treat them before 2 weeks. Okay? So ang dose niya nagre-range between 5 to 15 micrograms per kilogram per day, pero meron tayong precaution dyan. Halimbawa, yung ating Down syndrome, meron siyang heart condition kasama, medyo mag-iingat tayo sa dose. Kasi syempre, titingnan din natin yung iba't ibang mga kondisyones na meron din siya. Kasi di ba, yung ibang bata meron pang, meron din siyang heart condition, meron din siyang ibang condition na ginagamot din. So dapat titingnan natin yung coordination ng iba't ibang gamot. So dapat, daily dose yan, once a day lang po yun, minomonitor yan. Hindi pwede pagbigay ng gamot, hindi ka na magpapakita sa doktor. Kailangan magpapakita kayo kahit once every 3 months kasi dun lang makikita ng doktor, lumalaki ba yung aking pasyente? Tumataba ba? Sobra? Meron ba siyang ibang sintomas? Naha-hyper ba? Nasobra ba yung aking gamot? So importanteng makita yon talaga. And then, pangalawa, hindi lang kasi mahirap yung hypothyroidism kasi at saka yung sintomas ng Down syndrome kung minsan medyo pareho. Halimbawa, yung pagkamalumanay, number 1, pareho sila. Pag hypothyroid ka, malumanay ka rin pag wala kang treatment. Pangalawa, nako-constipate. Ganun din, di ba? So yung mga ganun. So it's hard to just say, wala naman siyang ganun kasi that's why you need the blood tests also. Yung blood test, yung ating FT4 tsaka TSH. Ha? So, syempre, role ng doktor na mag-reassess. Tama ba itong gamot na binibigay ko? Dapat ba bawasan ko? O pwede ko na ba tanggalin? Yun ang mga tinitingnan ng doktor. Kasi maaaring transient. Di natin alam. It's only with time na makikita natin. Depende kung meron o wala. Pero kung talaga wala siyang gland, pang life na po yun. So, syempre, ang pinakamahalaga, ihahambing natin yung gamutan natin sa paglaki at development. Kasi yun lang naman talaga ang ating role. Gagamutin natin para maayos ang paglaki at development ng ating mga children with Down syndrome. Para pag adult sila, healthy, hindi tayo sasabihin ng adult internist, hindi nyo inalaga ito maayos. Ngayon, ang dami niyang issue, di ba? So, ito yung mga haka-haka nila, no? Na bakit nagkakaroon ng hypothyroidism. Number 1, hindi pa daw mature, kaya delayed maturation of the hypothalamic pituitary thyroid axis. Pangalawa, baka may resistance daw. Kahit may thyroid hormone ginagawa ang bata, hindi maganda ang action niya sa iba't ibang organismo, organ systems. Pangatlo, hindi inappropriate yung release ng TSH. Hindi siya sumasang-ayon. Maayos na ngayong level, hindi siya sumasang-ayon. And then number 4, hindi siya sensitive. O number 5, hindi siya active. So those are biochemical terms. They are trying to look lang for reasons. What is causing the increased incidence of CH in Down syndrome? Okay? So, base doon, kasi nga madalas na yung subclinical hypothyroidism, yung congenital hypothyroidism, may mga guidelines po talaga. Ang American Academy of Pediatrics, ang kanilang guidelines for thyroid monitoring at birth, so dapat may newborn screening o gagawa ng TSH, 6 months, 12 months, and then every year thereafter. Kung walang nakikita, pero pag may nakikita, mas madalas na mangyayari yon. Sa United Kingdom at saka sa Ireland, aside from ito, sa kanila, by 1 year old, kailangan magpa-antibody test na rin. Kasi nakakatulong po ito doon sa sino ang magde-develop ng frank hypothyroidism at sino hindi. So nakakabigay ng parang warning. No? Pero syempre, practically speaking, medyo 4,000 pesos lang naman yon. So siguro gagamitin na lang natin yung pera para dun sa gamot at saka dun sa monitoring. Pero kung may extra money tayo, may funds tayo, it would be good to test. Ha? Ngayon sa Pilipinas, I'm a little bit more, I try to do it more frequent because alam ko naman the risk can happen earlier. So for me, I follow at birth, 3 months, 6 months, 9 months, and 12 months for the first year. In the second year, up to the 5th year, I do twice a year. Kasi mahirap na eh. It's very hard to distinguish yung sintomas ng hypothyroidism sa Down syndrome metabolism, which is a bit slow. Okay? So, ang guidelines din nila is when to treat yan kapag mataas sa 10 micro international units per ml or kapag may sintomas ng hypothyroidism. And usually, ang tinitingnan namin yung linear growth at saka weight gain. Suggestive yun. So how about hyperthyroidism? Nangyayari din pa ito? Yes. At ang pinaka-common na cause, yung tinatawag natin na Graves' disease. Ang ibig lang naman sabihin nun is, kasi si Dr. Grave, siya po yung unang nag-describe, kaya yan po ang pangalan. Pero actually, it's autoimmune in nature. Ang ibig sabihin nun is, masyadong mataas yung thyroid hormone levels niya. At on top of that, pwedeng lumuwa ang mata. Okay? So, ayaw natin yon. Huwag na natin dagdagan. Okay? May luluwa na nga dito, luluwa pa doon. So, gaano kadalas mangyari yon? Kung i-compare mo siya sa general population, ito 0.02% lang ang occurrence ng Graves. Sa Down syndrome, 0.66%. So, mas madalas talaga siyang mangyari. So, usually, nangyayari yan, di ba sinabi ko may autoimmune predisposition ang mga Down syndrome. So, usually, ang umpisa yan, namaga yung thyroid gland, yung Hashimoto thyroiditis. Kasi nga yung katawan niya, parang it fought against its own thyroid gland. That's what happens. Eventually, naging hypothyroid. So, bibigyan mo ng gamot. Tapos, nako-convert siya. Nagiging hyper na siya. Pero it has nothing to do with the antibody level, or the thyroid treatment. Gagamutin natin si Graves, of course. Kasi kung hindi, mahihirapan yung puso. So, ang gamot dyan, methimazole. Nawawala ba ito? Yes, remission ang tawag doon. So, usually, it can take anywhere from 2 years to 7 years. Pero pangkaraniwan, mga 2.5 years. Pero, oo nga, mawawala yung hyper, pero pwede pong bumalik. Yun ang ibig sabihin ng remission at saka relapse. Yun ang isang characteristic ng isang autoimmune disease. Hindi mo talaga siya matatanggal. Hindi mo talaga siya maku-cure. Kasi nga, parang ang nangyari, naging hyperactive yung immune system ng bata, ng tao, against his own organs. So, it's very hard to treat that. But hopefully, in the future, they will find treatment for that. So, that's why, kung minsan, okay siya, pag okay siya, no treatment. Pag hyper siya, bibigyan mo ng treatment. Kaya yung iba, sabi nila, mabuti pa, sunugin na lang. Yan ang tinatawag natin na radioactive iodine ablation. May gamot na ibibigay at preferentially itatrap ng thyroid, masusunog siya. Pero, ang long-term side effect nun, gamutan na ng thyroid hormone yung bata. Okay? So, because of the autoimmune predisposition of children with Down syndrome, meron silang ibang mga autoimmune non-thyroid manifestations. Pero you also look at it when you have the thyroid condition. So, usually nagkakaroon sila, nahuhulog ang buhok, no? Aryata means patchy, no? And then vitiligo, yung namumuti, napuputi yung skin, at saka celiac disease. Okay? So, yung pangalawang condition is growth. Just remember, may growth charts na po tayo sa Down syndrome. And I know that several years back, in the time of Mr. Elmer La Peña, I know that his wife had actually had a program that actually spearheaded the making of growth charts for Filipinos with Down syndrome. So, I don't know whether you are in that project, but for now, we have updated and published 2015 growth charts from the United States, which were updated from 1988. And just the point being here is when we chart the growth and weight of our children with Down syndrome or adolescents with Down syndrome, let us use the proper charts. And monitor, hindi lang plot lang tayo ng plot, tapos wala tayong gagawin doon. Titingnan mo, ito ba ang kanyang timbang maayos sa katangkaran niya? Ang timbang ba niya pababa para sa underweight ba siya para sa katangkaran niya? Overweight ba siya para sa katangkaran? You do not measure it against the age. It's against the person's height. Kumbaga, weight for height. Okay? And yung height niya, nandun ba yon kung saan expected? Okay? So what they really are looking for is obesity prevention. And at starting 2 years old, you have to watch really these children because they really tend to weigh much more than their non-DS peers because they're less active. Okay, they're hypotonic. They can't run as fast. They can't be as active. They might have a heart disease pa. So it's recommended that their dietary calories should really be less, no? Compared to the unaffected children. We should encourage them physical activity within what they can do. As long as meron pong activity every day. Ang recommendation po ng World Health is everybody should really be active at least 1 hour every day, lalo na pag very young. And then make sure that they have enough calcium and vitamin D so that yung kanilang bones are also strong. Okay? Now, the third condition is diabetes, type 1 diabetes. It has to do again with the autoimmunity. So Down syndrome have increased rates of diabetes-related autoantibodies. And then kung ikukumpara mo yung children with diabetes na Down syndrome at saka children with diabetes na not Down syndrome, actually pareho ang pathogenesis, pareho ang sanhi ng kanilang diabetes. And what is that? These are actually islet cell autoantibodies. Dito sa slide na to, makikita nyo, they had 106 Down syndrome patients. And then they had 2,000, okay, healthy school children. Pero pay your attention dito, itong mga GADA, islet cell antibodies 2A, islet autoantibodies, ito yung mga markers na pag positive ka doon, ibig sabihin meron kang type 1 diabetes, hindi type 2, type 1. So, pag ikukumpara mo yung prevalence, yung gaano kadalas mangyari, doon sa GADA, tinan mo yung Down syndrome, 1.9% versus 2%. So, pareho. Tapos, tinan mo yung islet cell, 2A, 2.8, 2.1, pareho. Nag-iba lang sila dito sa islet cell antibody. Yung islet cells, yun yung cells mo sa pancreas na gumagawa ng insulin. Pag namagayan at nawala yan, ang nangyayari, kukulangin ka ng insulin, magkaka-type 1 diabetes ka. Okay? So ngayon, kung ikukumpara 4.7 versus 2.1. So same thing with the others. So pareho ang sanhi, pero mas mataas ang antibody levels ng mga Down syndrome. Kaya mas malaki ang kanilang chance of getting type 1 diabetes compared to the regular population. Okay? So, ano pa yung bago ngayon? Sinasabi rin nila, kaya rin mas madalas magkaroon ng type 1 diabetes sa mga Down syndrome is dahil dito sa itong autoimmune regulator na AIRE. Ito po ay isang transcription factor na kinocode ng isang gene na nakalocate sa chromosome 21. Ialala nyo, di ba, ang pinakamadalas na Down syndrome, ang sanhi niya po ay Trisomy 21. Okay? So can you imagine, 3 kopya niyan. So kung meron ka nitong gene sa Down syndrome, hindi maayos yung function ng thymus mo, yung immunity. Kaya yun ang nagbibigay ng autoimmunity risk increase. Okay? So, yung bang incidence of type 1 diabetes among Down syndrome, mataas pa? Okay, wala ako makita dito sa Pilipinas. Pero sa Denmark, nung tiningnan nila yung population nila, yung National Registry from 1981 to 2000 newborns, okay? They had followed them. Nakita nila na talaga dun sa mga, yung type 1 diabetes was more common, 0.38% versus only 0.09% in the regular population. Okay? Tapos dito naman sa lugar na ito, they looked at 4 diabetes clinics at nakita nila yung incidence ng type 1 diabetes at among the Down syndrome was anywhere from 1.4 to 10.6. So it's significant. Meron talaga nag-exist. Kaya bakit to sinasabi lahat sa inyo? Para alam nyo na talagang nangyayari at siguro we should be on the lookout for it, no? So anong treatment dito? Usually insulin injections. Siyempre, nakakatulong din yung diabetic diet, hindi masyadong kakain na masyadong matatamis. mag-exercise din. Dapat din maintindihan ng bata at ng pamilya kung paano dapat mag-inject. Kailangan mag-glucose monitoring. Kasi kung hindi mo iintindihin at kung ano yung kondisyon ng bata, hindi mo siya matutulungan. And syempre, ang goal natin is matutulungan natin siya. Okay? So, pag type 1, kailangan insulin talaga. Okay? Now, question, meron din bang type 2 sa Down syndrome? Kasi isipin mo, mas madalas marami kasi mas malaki, dahil ang metabolism, medyo mas maraming obese, di ba? Tsaka overweight sa mga Down syndrome. Actually, naghanap talaga ako. Ito yung mga iniisip nila na, syempre, pwede ka magkaroon ng type 2 diabetes sa Down syndrome kasi impaired na yung kanilang insulin sensitivity, tapos impaired pa yung beta cell function nila. So, nakahanap ako ng isang journal na nagpakita na meron silang na 15 patients na may Down syndrome. Actually, yung 5 dun sa 15 adults na. Yung 9 adolescents. Yung isa dun pre-adolescent. Lahat sila overweight at saka obese. At lahat sila may insulin resistance. Yun ang first step eh. Pag may insulin resistance, magta-type 2 diabetes ka na. Okay, so talagang ang point nito is we have to watch our children with Down syndrome. Proper diet, vegetables, make them move because as they gain more weight, tumataas yung risk nila for type 2 diabetes. Okay? So, ano ang treatment? Diabetic diet, lifestyle, meaning dapat maayos ang tulog, may exercise, maayos yung ora, hindi pwede masungit parate. Tapos, kung talagang kailangan, hindi makukuha sa diet modification, weight loss, and exercise, kailangan ng gamutin. Tapos later, pag hindi pa gumagana ito, bibigyan na natin ng insulin. Okay? Kaya, maaga pa lang, kaya nga sinabi, di ba, at 2 years old, bantayan nyo na ng maayos yung mga children natin, mga pamangkin nyo, mga apo nyo, o mga anak nyo na may Down syndrome, na yung kanilang kinakain, yung kanilang lifestyle, try to make them active. Because as you start early, they will learn these habits also. And if pag nakasanayan na nila, di paglaki nila, hindi na kailangan kulitin. Di ba? Eto. Puberty and fertility. Anong guess nyo? Delayed ba ang puberty ng mga Down syndrome? Of course not. Pareho lang. Usapan natin ang males, ha? So, ang puberty nila, normal onset, normal completion. So, ang pangkaraniwan is anywhere from as early as 9 to as late as maybe 14 in boys, no? So, ganun din. Hindi siya madidelay. Ngayon, ang problema, pag naging adult sila, hindi yung haba ng kanilang penis, hindi sing haba ng pangkaraniwan na adult. Yung kasing age nila na adult, hindi rin. Pangalawa, yung volume ng kanilang balls, yung testis niya, below average din. Kasi nga, ang nangyayari, tawag nito, primary mismo doon sa kanilang testis, hindi maayos yung tinatawag natin na spermatogenesis. So, part of the effects of that extra X chromosome. Okay? Tapos, pag kinuna mo ng blood nila, makikita mo, maayos naman, mataas naman ang kanilang FSH and TSH. Problema, and then normal naman to. So, magtataka bakit? So, most likely, inherent doon sa kanyang gonads, no? So, in this case, they look at 53 males. Okay? Next. So, ang males, ang question mo, are they fertile? Yes, but low fertility. But there have been instances of males fathering children. So, it can happen, but not as often as it happens with females. No? So, in females, puberty, again, is normal onset and completion. Nagme-mens din sila. Fertility, actually, while some of them, 50% of them will have primary gonadal deficiency, meaning some of them may not have good function of their ovaries, but they have actually higher fertility than the males. So they still can have children. Okay? Now, for both males and females, yung gonads nila, so sa girls, sa ovaryo, sa boys, yung testes, progressively nagiging hypofunctioning na sila, no? More from birth to adolescence and into adulthood. But as I said, fertility is possible, and I will show you, no? Ay, bakit ano nangyari dito? Miss yata ng isang slide. Okay, so yes, that's why nga AAP guidelines from 13 to 21 and beyond, dapat nagdidiskusyon na kayo tungkol sa pubertal changes, sexuality, parenthood. Huwag tayo magtataka kung yung anak nyo o yung apo nyo o yung pamangkin nyo nagkakaroon ng crush. Diba? Kasi normal po yun sa kanila. Okay? Yun nga lang, when they are beginning to understand, then you have to start teaching them little by little what is the age-appropriate behavior, and then also teach them about how eventually babies are made, because you want to make sure that they understand also, because syempre, not all of them will have the capacity to be able to take care of a child. So it is good that they understand it early enough. Okay? And of course, you also have to tell them there is a risk of Down syndrome recurrence in an offspring. If I am a female with Down syndrome and I get pregnant, the risk of my baby having Down syndrome is actually higher than somebody who didn't have Down syndrome. Okay? So here, I will show you this study. Although it's quite an old one, in 1982 pa ito, pero there were 26 affected mothers with Down syndrome in 30 pregnancies. 10 of the babies actually had Down syndrome. 18 were not affected, but there were 3 spontaneous abortions. Other risks for the mother: difficult labor, miscarriages, and prematurity. Usually 75%, pag Down syndrome din yung baby, usually na spontaneous abortion siya. No? So that's what I wanted to tell you. Now let's talk about bone mass. Down syndrome are at risk for low bone mineral density because of their propensity for obesity, because they're not active. They have low vitamin D. They do not like to go out in the sun. They have low muscle mass because they're not moving. And some of them have malabsorption. So because of that, we think about bone health. How do you actually measure bone health? It's actually measured by bone mineral density. So yung bone mineral density, maraming methods yon. Yung pangkaraniwan, yung tinatawag natin na DEXA, Dual Energy X-ray Absorptiometry. Unfortunately, short ang mga Down syndrome katulad ko. So, ma-underestimate. Sasabihin, ay nako, osteoporotic ka kasi maliit. So, mas maayos sana kung ang gagamitin nila yung tinatawag na bone mineral apparent density or yung volumetric BMD. I'm sorry, I don't know. I have not had a chance to look at which health facility, hospital is actually doing this. But that would be. So, halimbawa, ito lang ang meron na tayo. Basta just back of your head, alamin ninyo na dapat meron siyang adjustment for short persons. So, ito yung nakita nila, no? So, in this particular study, nakita nila na talagang mababa yung bone mineral density in Down syndrome. And ang ginamit actually nila was the BMAD, no? So, ang nakita nila dun sa 234 na adults with Down syndrome, and then they compared it with the natural, yung mga normal population, no, na 22,000. Ang nakita nila, using the BMAD, yung mga Down syndrome na 40 to 49 years old lang, yung buto nila parang 60 to 69. So talagang hindi maganda ang bone health, no? So ano yung general consensus? Ang alam natin is, sa Down syndrome, mababa talaga ang bone mineral density. Dahil hindi talaga nila alam pa kung dahil masyado bang mataas yung bone turnover o yung bone resorption, or hindi lang gumagawa ng bone. So, kailangan pa ng research doon. Kaya ko binabanggit ito kasi nga pwede siya magkaroon ng fracture risk. Okay? So, how do you address low bone mineral density? Maaga pa lang. Their children pa lang, you have to make sure they have enough calcium and vitamin D. Weight-bearing exercises. Yung use of bisphosphonates na ginagamit ng mga adults, not yet recommended. Kasi hindi pa nga nila alam eh. Kasi at saka alam nila, low ang bone turnover. So ano pang ibababa ng bisphosphonates? Ha? So you have to make sure na lang children have adequate calcium and vitamin D. And dun sa vitamin D is on our skin, and by exposure to the sun, i-activate yung vitamin D. So, yun ang natural source. Di na kailangan magdagdag. Pero meron pa rin mga dietary sources of vitamin D sa gatas, sa isda, di ba? So, yan, no? So, these are some of the rich sources of vitamin D na dapat i-encourage din natin sa ating mga children with Down syndrome and even children without this condition. And then, ito ang mga calcium sources na pwede natin gawin. Yung malunggay, nako, dami-daming calcium tsaka broccoli. So, ito rin po, no? So, pinakiusapan na ko na dapat sabihan ko rin ito, no, na meron po talagang guidelines from before birth up to adulthood. So, ito yung guidelines na sana lahat tayo, we should be aware of so that alamin din natin yung total well-being ng isang batang may Down syndrome. So, at birth, dapat magawa lahat. Natingnan siya ng maayos, may genetic testing na talagang para malaman ano ba siya, trisomy ba siya, Robertson ba siya, mosaic ba siya, tapos ma-counsel para maintindihan ano ba yung feeding niya, check kung may heart condition siya, kumusta yung hearing, kumusta yung pagtingin niya, ano yung thyroid niya, newborn screening, tapos syempre tingnan mo rin, may anemia ba siya, tingnan mo kung may problem siya sa GI, butas ba ang puwet, kung may obstruction ba, may infection ba. Tapos, maghahanap na kayo ng developmental services, ha? Tapos, yung mga resources. Tapos, pag 1 month to 1 year, ganun din, pero ngayon, dadagdagan mo na. Immunizations, growth monitoring, kumusta ba yung leeg niya, may social support ba kayo, tapos, kailangan din mag-isip-isip na din yung nanay, at saka yung pamilya, yung recurrence risk. Kasi kung minsan, they also want to have another baby, ha? So, pag 1 to 5 years, the same thing, pero ngayon, dagdag mo na. Mas masuri mo na, titingnan mo na, kumusta ba yung gastric niya, maayos bang paglaki ng anak ko, sleep pattern, natutulog mo na maayos, may mga skin manifestations pa, nakukulog ba yung hair, yung mga ganun, no? And then, may mga seizures ba siya, or mga signs of seizures, kumusta yung ipin, may bagong treatment ba siya na makakahadlang sa kanyang development. Tapos dito talaga pupuntahan yung mga developmental pediatricians ninyo kasi sila ang magbibigay ng gabay kung paano na pwedeng bigyan ng advantage yung mga Down syndrome, di ba? Tapos pag 5 to 13, lahat yun plus nako, titingnan nyo na to. Kumusta na ba ang behavior ng batang to? Kumusta ba ang mental health? Nakaka-adjust ba? Kumusta yung mga kapatid nito? Inaaway ba siya? Binubuli ba siya? Tapos kumusta ang progress niya sa school? Yung puberty and sexuality, dapat medyo alam ba niya kung lalaki siya? Alam ba niya kung babae siya? Siguro naman, by 5 years old, alam na niya yun. Ano? Pero it's about time that they already are aware of physical changes of puberty so that they don't get scared, okay? And tell them it's a natural process of growing up. Tapos, syempre, yung mga medyo advanced dyan, medyo sasabihin mo rin, no? May fertility yan, sabi mo, gusto mo ba mag-anak? Pag nag-anak, kaya mo ba? Sabi mo, kakayanin mo na sarili mo. Then you can think about that. Yung mga ganon, no? So, finally, from 13 to 21 years old, ito na yung next speaker natin. Pag-uusapan niya yung transition at saka pinag-usapan na Dr. Alexis yung aging. Okay? So, bakit ba natin pinag-usapan lahat ito? Kasi nga, ang overall prognosis of having a child or a person with Down syndrome is good. Like, you can optimize his potential just like a regular person. It's really up to you. So, your lifespan, tinan mo dati, 25 years lang. Tinan mo ngayon, 60 years old na. Diba? And the median survival is mid-50s. 75% yung conceptus na Down syndrome, usually nag-fetal death na. 23 to 30%, 25 to 30%, usually in the first year of life, yun talaga ang pinaka-critical. So, you have to watch them kasi some of them really die because of bronchopneumonia. Okay? So that is, I think, my last slide. And in summary, we went through the conditions that were associated with the endocrine system, and we went through very, very quickly the general health recommendations. So I have ended my lecture. 10 minutes ahead, and I hope you will find time to ask questions. And before doing that, I'd like to say thank you so much po. Maraming salamat. And congratulations po, Down Syndrome Society of the Philippines, Help Learning Center Foundation, the City of Naga, and Northfield. Thank you very much for this wonderful, wonderful event. Maraming salamat po.
Thank you very much po,
I
Dr.
will stop.
Sylvia. Opo, you can stop
Opo,
sharing na
stop
po.
Pages
Thank you
on
so much po. Ngayon, request lang po for the non-speakers, pa-off po ng video because we are currently having really bad connection problems. So, pa-off na muna po ng video ng mga hindi presenters para mas smooth yung process kasi yung MC mismo hindi makapasok. So, Sir Luis, pa-off muna po ng video. And thank you very much, Dr. Sylvia. May mga questions po sa chat box if there are some people asking there. So, una po is previews at 2:05 from Ma'am Salvador. What are the signs that the Down syndrome child has hypothyroidism? And then there are two more sa ilalim po. So, since we have time, may we ask you to answer the questions?
Okay. So, which one shall we start with first?
The first one po, nasagot ni Dr. Alexis, but you can also add on that. What are the signs? I-paste ko po. So, to all, here we go.
Okay.
Yan po.
Okay, wait lang here. What are the signs that the child has hypothyroidism? And my child is excessive. Should I consult an endocrine doctor? Okay. So, signs of hypothyroidism. One of the first things you'll notice is very lethargic. Ayaw gumising. Kahit maayos yung tulog niya, 8 hours of sleep, ang mahirap-hirap gisingin. That's one. Number 2, kung halimbawa ang pangkaraniwan niyang pagpupo is every day, sometimes every other day, or every day pa rin pero ang tigas. Number 3, low energy. Low energy. Number 4, sometimes maputla po sila. Well, that's really sad. So, it's very hard, no? Kasi parang very similar ang symptoms. So those are, then sometimes, very rough po ang skin nila. Okay, so those are some of the signs. And then falling hair can be a sign of either hyper or hypo. Kasi remember, I talked about alopecia areata. Yes, ganun din po yun. And then sometimes you look po at the neck. Pag medyo lumalaki po siya, and then palunukin niyo po yung bata. Pag nakita po niyo meron pang, baka malaki ang thyroid. So, you can go to an endocrine, or we can go first for your pedia, or your adult. Kung adult na po ang anak nyo, dun sa adult, pakita nyo lang po, and pwede po niyang tulungan po kayo doon. No? And then, what else? Signs, excessive. So, yes, I would suggest, actually, the first, should you consult an endocrinologist? If you have a family physician who is capable naman, para she can do the general screen, okay din, you can do that already. Kasi you can also order already for that. If you're worried, could be thyroid, you can already do the FT4, and if you're thinking hyper, so FT3 and TSH, yung tatlong pong yan would be good. Okay? And then, let's see, what else pa?
May dalawa po dyan na questions pa.
Okay, can Down syndrome be detected early or during pregnancy? Yes. Actually, although we don't do that in the Philippines. Okay. In more advanced centers who actually offer termination of pregnancy, they have markers that they look for that will suggest that this is Down syndrome. And actually, it is highly recommended in those families where there are two already, two siblings or two offsprings, because you can actually have mosaicism. You have to rule out mosaicism, and mataas ang chance of recurrence in mosaicism. So dapat the parents have to be tested also. Okay. And is hypothyroidism hereditary? Can it be passed by the... Ay, hindi po. Unless po... okay, is hypothyroidism hereditary? Usually no. Okay. unless it's in very, very rare cases, you can have a genetic syndrome that causes hypothyroidism, and it's passed on family to family. Pero you're talking about the thyroid, hypofunctioning thyroid in a pregnant mother, will she pass it on to her child? No, but if she did not treat or did not manage her hypothyroidism in utero, that child can actually become affected in terms of her growth and development in the future. Okay, so depending on what the child has, but generally it's not the hypothyroidism that is associated with Down syndrome is not inherited. It's because of, number one, either an immaturity of the hypothalamic pituitary thyroid axis. It can also be because your TSH is not responsive to your thyroid hormones, or your TSH is not active, so it's not doing its job. It's supposed to stimulate the thyroid, yung mga ganun. So right now, hindi pa po yun ang kanilang iniisip. Is there anything else? Did I miss out on anything else? At which gestational stage can DS be detected? Gestational stage. Depending on the marker. If they're going to do chorionic villi sampling and they're really going to go for the genetic marker, as soon as they will allow you to have the chorionic villi sampling. But I know that I cannot remember what is the ideal age, because you run the risk of losing the pregnancy if you do it too early. So alam ko po, it might be after the 20th week. I'll have to check. I'll have to get back to you on that. Okay? Ano pa? Sorry. Okay. We have a member whose adult daughter's DS was given Lexapro, but there were adverse side effects, which has been traumatic. Oh, I'm so sorry. What should be the proper approach from the supervising doctor? I think other person that would have. Okay. All right. My advice to the mommy of the question here is, if your child was given Lexapro is it's one of the psychiatric medications. It might be used sometimes for anxiety. It's also used for depression. Okay. Generally, depending on what it was indicated for, and depending on the dose, sometimes depending also on the psychiatrist or the psychologist who gave it, they will start. Some people start low dose. Some people will start at a medium dose. So let's say this patient's on 10 milligrams, baka pwedeng ibaba. That's one. But if it was really a very bad reaction, I would suggest first, maybe the question is, how is your relationship with that healthcare professional? Because if it's a good relationship, then maybe you can be honest and tell the healthcare professional, it didn't work well for my son or daughter. And so is there anything else that we can try? Can we do psychotherapy? Can we do behavioral modification? Kasi depende po kung bakit po siya binigay. Okay? And then of course, let's say you're not too happy, then maybe it's also naman an option for you to get a second opinion. Diba? And then maybe you also check the other medications that are being given to your son or daughter, so that you can see baka may bad interaction po. Okay? So yun po ang pwede nating, those are my kinds of advice that I can give you. But I would suggest really strongly maybe delving into the reason first. Diba, no? Ayan. So may tanong nga si Dr. Alexis dito. What is the reason for the Lexapro? Ayan, Alexis. Mas maraming experience si Dr. Alexis dito.
Lalo kung hindi masasagot yan. Pero I was just wondering why the individual was given Lexapro. So there are many side effects to any medication, but the reason for this is the question. So maybe they should go back to the prescribing physician and ask whether there should be a change of medications and what prompted this medication to be given in the first place. So, yeah, just my thoughts.
Very good thoughts. Okay.
Thank you,
Ito, may isa pang... I love it. Okay. The next one here is, ano po ang test para malaman ko po na I need to go to the endo? Ma'am Sahagun, teka muna. You saw the guidelines that I posted. Okay, from the endocrine standpoint, I don't know how old are you, Ma'am Sahagun? So if you're an adult na po kayo, definitely if you're above 13 yearly and you don't have any endocrine pathology right now, you should be doing your screen for your thyroid. And especially if you notice that you have a big neck, baka it's your thyroid, then you probably need to do antibodies as well. But you need to just check that. And then if you are on the obese side or overweight side, huwag naman natin sabing obese, generally overweight, so you might want to do at least an HbA1c just to screen if you're having some glucose intolerance, okay? Okay, so Ma'am Sago, did you want to elaborate?
We'll have to stop the questions here po because it's
Okay.
2:30. If there are any more questions, paki-chat na lang po and Dr. can answer via chat. Now, ang next natin, we are looking for Dr. Emma. Are you here po?
Yes,
Kasi
I'm
may
here.
mga...
I've
Okay,
been here
good. Ano
since
po?
morning. Yeah.
Ang weird ng names na you're using ang pangalan sa nanay ko eh. So let me just
Really?
change the name para ano.
It's me.
I don't know why that's happening, pero good afternoon po. It's your turn po to present.
Yeah,
Sige
okay.
po.
So I'll just share my slides. Hold on. Babu, thanks for that lecture.
You're welcome.
So, do you see my slide? And how's my audio? Hello?
Audio is
No
clear.
slides.
Oh, blackout.
No
No
slides?
slides. Wala.
Wala nga slide, black.
Oh my God. How about this one? Wala pa rin?
Still
Wala.
blackout po.
Ooh. Okay.
Lumabas na kanina, Emma.
Huh?
It was out na. I saw it already. And then, nawala.
Okay, so maybe I'll just stay a bit. Do you see anything?
Wala pa rin
No.
po.
Okay. How about this one?
Nope.
I'll just check my connection, huh? And,
There it is.
We see it.
Oh, okay, great. Sige, I'll
But-
start. How about that?
Nope, nawala.
Eps,
Okay,
I think
Dr. You have to stop sharing muna po. Stop sharing.
I'll stop share.
Okay, and then run the PowerPoint. After you stop sharing, run the PowerPoint.
Mhm.
Stop sharing po. Yan. Then run the PowerPoint before you share.
I did that several times before this happened.
Opo.
Oh my God.
Minsan. So, is the PowerPoint running? Okay na po siya?
Sandali muna.
Sige po.
It's available. Sandali. How about that? Do you see it?
Okay, now i-share nyo na po. Share, but this time, pick the big picture, not the one with the slides. Pick the one with your first slide.
Okay.
Screen share, and then select the image of your PowerPoint.
You see it?
Yes po. Thank you po.
Oh, great. Thank you. These things make me nervous. But anyway, thank you. Thank you for that assistance. And thank you for the previous speakers who have actually made my work a lot easier because Alexis discussed a lot of the issues that older adults with DS have. And of course, she had and also we listened to Samantha. And this is actually was my first slide. I wanted to ask the audience what they wished for their kid, but just listening to Samantha and listening to Mr. Paradyang and looking at the videos, it's clear what we wish for our kids. And this actually just summarizes what we want them to be and to have, to have friends, warm relationships, to be safe, to be independent, to be employed, to have access to healthcare, which has happened in Samantha's case, which was really beautifully um, exemplified. And I think I like this slide and I like this saying because it says we should start with the end in mind. And when you say an end, it means a goal. And our goal, obviously, is a child who is well adjusted and happy and has friends, is safe, has access to healthcare, is independent, and is employed. But you can, when you identify your goals, even at the get go, even when the child is still an infant, you get to plan. So identifying our goals, identifying our dreams for our kids, and what I remember what Mr. Paradyang said. Also ask your kid what his or her dreams are. It's not only you, it's also her life. So also ask what her dreams are like, and spend the next years um, doing whatever it takes to reach that dream. And why we should do that, as I just really emphasize, it's because we expect them to live to their 50s, even their 60s and 70s. I just grabbed this picture from the internet. This is the cast of uh, three of the seven young people with disability, and they have a reality show entitled Born This Way. And it just documents all the challenges and all the joys of living in a community, living as fully as possible as members of a community. I don't have a relative with Down syndrome. All my contacts have been through what the patients we see in PGH. But as a child, I was neighbors with this actor. This is Vincent Biado. I don't know if you're familiar with this movie. This is um, about 2 years ago. It was quite a hit, and I think you should really look for this movie. It's funny. It was very well done, but what I really loved about this was the way they approached and treated him. No, he was treated with much dignity the way the script was written, and in the end, he was the most matino of all the family members. No, and why is Vincent Piado important to me? It's because he was a neighbor. I'm from Cebu, and he lived across our house. He was one of 9 kids, and from the start, um, his parents were just obviously loving and treating him with affection and respect. And the whole neighborhood just followed the way they did. So he was never bullied, and he was given chores and responsibilities. And I remember seeing him um, riding his bike as he went through his chores and going to school. So, so he also exemplified to me when I saw this movie the potentials, no, of children and adolescents and adults with Down syndrome. So it has changed a lot. It's not only the life expectancy that has changed, but it's also the attitude, no, of people. Yes, there's still discrimination. We know that, but generally there's an opening up, no, and a realization that they do have potentials. They can be somebody like Samantha, and so that that is um, that is my mindset as I was preparing for this talk. And I just wanted to talk about not only healthcare transition, but really all the other transitions that happen during adolescence. No, and it's not only pubertal growth and development, or looking for another doctor to take care, no, of the adult needs, but it's also striving towards independence. However, that might be possible given the cognitive abilities, and also that one another transition that that needs to be done is school and employment, which Archie will discuss later on. So in the next few minutes, I'll talk about adolescent growth and development, which was touched already by Dr. Estrada, and how to keep and how to grow healthy adolescents and young adults. And just talk about, I'll end with a description of what we do in PGH. Okay, so a question here is, are they any different? No, as Dr. Estrada mentioned, in terms of physical growth, in terms of puberty, they have the same. They will develop like any other typical adolescent. No, it's just that the sequence will be the same. The hormonal changes will be also the same, except that for the psychosocial and cognitive development, that may be a little delayed. I'll explain a little later. So just a review, because I'm sure there are mothers and parents in the audience who are quite who have young children, and this is something that we should understand and we should know so that we are able to deal with it, with puberty and all the changes when they come. So for girls, the average onset is at 10. When you say onset, that means the appearance of breast buds, no, or breast development. Now remember, this can happen as early as 8 years old or as late as 13. So you see a variability of 5 years. So it can be different. No, the onset can be very variable. And what are the things that? What are the factors? It's nutrition. No, well-nourished adolescents actually can enter puberty a little earlier. But if they have a chronic illness, for instance, a heart disease, they can have delayed puberty. So it's nutrition and the presence of a chronic illness that can affect the onset of puberty in females. Also, the hormonal status, as mentioned earlier, hypothyroidism can actually delay the onset of puberty. So that's why it's so important to take care of the endocrine health of our adolescents. Now, these are the events, no? So breast development happens, and then you also have the development of pubic hair. Okay, menstruation happens like most typically at 13 years old. Initially, the first 2 years may be irregular, like most adolescents. They can have an increase or a height spurt, no, before menstruation. And there's an increase in weight that is normal, but we want to check that weight gain and make sure they don't become obese, because that also predisposes them to hypertension and diabetes later on. Basically, the shape of the face, actually, there's a little elongation, but usually kids with Down syndrome have a roundish face. The body may change because of the deposition of fat. Of course, like all adolescents, they will have problems with pimples and body odor. Now, for the boys, they have pubertal development to about 2 years later, no? So the girls always come earlier, the boys later. As early as 9 again, and as late as 14. So very variable. So it might be it's not a good idea to compare two adolescent boys, no, because of the variability in terms of the onset of puberty. And it's very subtle, no? The changes are quite subtle. It's the enlargement of the testes. If you remember, Dr. Estrada mentioned that in terms of volume, the volume of the testes of adolescents with DS actually is smaller, no? But this is the first sign. It's not the breaking of the voice, it's not bulbous, but it's actually the enlargement of the testes. And these are the other changes, no? The development of pubic hair, body hair, armpit hair, then the changes in the scrotum and the penis. There's first an elongation and then a broadening of the penis. Try to remember, I'm just trying to string up all the things that were discussed. The average penis size is in the low normal, no? Okay. So like the girls, they have also an increase in height, which is 2 years later. So initially, the girls might be taller and the boys will feel they're short and feel insecure, but eventually the boys will be able to catch up. Now there's increase in weight and muscle tissue. The boys actually gain muscle, but the girls lose muscle and have more fat deposition, no? So they also have problems with more actually in terms of pimples and body odor. It's because of the testosterone. The thing that we need to also understand, and parents uh, seldom talk about, are actually the things that happen to normally to the bodies of boys. They will have erections, no? They will also have nocturnal emissions or wet dreams. So this is semen that spills out as the body tries to calibrate, no, its production of semen. There's also sperm production, but as mentioned by Dr. Estrada, they usually have low fertility, but still they have erections, they have nocturnal emissions, and production of sperm. So they can actually impregnate, but not that often, as mentioned by Dr. Estrada earlier. Okay, so like any other teenager, they also will have emotional and psychosocial changes, but with a lag, no? The physical part of it, just any other typical teenager, but with psychosocial changes, maybe a 3 or 4 year lag. And then, but it's, the contents, the feelings are almost similar. No, they're concerned about their appearance, so they may not like to wear the clothes that you bought them. They might want to put in makeup, no, and they become they can become very self-conscious, and they become very modest, no. And because of this, you need to give them personal space and privacy. And they're not very conscious at this time, please teach them that they can't just go around stark naked in the sala. So we also need to teach them some uh, privacy and modesty at this time. They will have emotional mood swings. They will be emotional. That's how they react, and there will be mood swings like any other teenager. They seem to be happy one moment and then sad the next moment. Now, they, like any other teenager, they want to be independent and autonomous and want to try things out, which is not entirely bad, no? And we want to encourage it in a good way. Okay, like any other teenager, they are curious about sex. They have sexual feelings. As Dr. Estrada mentioned, they will have crushes. They become interested in love and relationships, and which can be frightening to all parents, not only parents with uh, kids with disability, but all parents are scared of this aspect of adolescent development. I'd like to talk a little bit about the adolescent brain. No? In teens without disability or DS, brain development has been found to be completed at 25 to 26 years old, and not earlier. We thought initially that by 16 or 17, when they're parang mama na yung hitsura nila, that the brain is also developed, has to also already finish developing. So it's not true. No? So the MRI scans have found out that actually brain development continues until we're in our 20s to in our early 20s. So what happens, what's interesting here is that the brain development actually is quite uneven. So this is the view of the brain from the top, and this is the front of the brain, and this is the back of the brain. So the blue parts are actually the parts that have matured or myelinated na siya. And we see that the back of the brain, actually, development progresses from the top, from the back of the brain, and ends up here on the last part. Why is this significant? Because at the back of the brain is the limbic system, which is the emotional part of the brain. That's why they react to things very emotionally, no? And what's last to develop actually is the prefrontal lobe here, no? In our forehead, no? And this is the manager or the CEO of our brain. So this is the one in charge of impulse control, decision making, planning, judgment, thinking of consequences. So if you are familiar with teenagers or look back to your own adolescence, remember we were not very good at impulse control or decision making or planning or judgment. Kahit smart tayo, we still made really weird decisions, no? So in those without DS, brain development is not done until you're in your mid-20s. So you can imagine that there will also be a lag in terms of brain development, in terms of social maturity, emotional self-control, social communication, abstract thinking, and problem-solving ability. No, It also depends on the cognitive disability that the adolescent has. So what's the point here? The point here is that we should really intentionally teach them decision making, emotional control, because this comes later, and this could teaching them could actually keep them safe and help them develop skills that they need as adults later on. Okay, so knowing all of that, there's a huge amount of growing, developing. I mentioned, development of your breast, the reproductive organs, the muscles, also bone development, by the way, which you have bone banking. Like 40% of the bones actually are produced or are built during adolescence. No, so there's a huge demand for calories and vitamins and minerals, no? Especially calcium and vitamin D and zinc, which is needed for reproductive health. So we need to make sure that they have a balanced meal, no? And what's a balanced meal? With all the fast food, it's quite difficult to figure out what's a balanced meal. But go to the website of FNRI, and you can see samples of meals, no, that are appropriate for male adolescents and female adolescents. So this is the Pinggang Pinoy. You actually divide your plate into four. So one part is the carbo, that's your rice. One part is your gulay. One part is your fruit, and one part is your protein source. So this gives you an estimate of what is balanced, no, what is needed per meal. Okay, so adolescents need more sleep than they are getting right now. So they need 8 to 9 hours of sleep, and we take sleep for granted, but their studies have shown that it has an effect on our mood. It can actually predispose us to depression. It can affect our attention, no? It can affect the way we learn. So sleep is very important and should never be underestimated. And we should develop good sleep hygiene practices. Physical activity, emphasize again, is much earlier. It may be a challenge, but if you remember what Samantha does, she dances, no? They can go online, watch videos, and just follow. And parents can actually join the children doing the physical activity. And if it's possible, go out and have some sun. You need the vitamin D as you're doing your walk or your exercise outside. Now, this may seem impossible because we're online much of the time, but the point here is that limiting screen time actually gives you time, or gives the adolescent time to do other stuff, no? Because if they're stuck there just in front of the screen, that's not good for their cardiovascular health or their mental health, no? And before I forget, parents should talk about pubertal changes early. And remember, the girls can have breast development as early as 8 years old. So please start talking about the possible changes by 7 or 8 years old. Don't wait until they menstruate and they're scared of the blood on their panties, on their underwear. That's going to be very traumatic. So please learn what are the changes. There are a lot of good resources online. I can point you there, but please study and then learn and be able to talk to your adolescent. What else can we do? Please make sure that they dress appropriately for age. I've seen adolescents or young adults being dressed up like kids. No, it's like infantilization. Parang they're treated as children. No, they're not. They're growing up and they should dress appropriately, but not hypersexualized, too sexy naman. No, that's not appropriate. Okay? Now, important to teach personal hygiene. They become mabantot, by the way. But the point is they should be able to take care of themselves. And if they're not yet able to do this at this point, it is a goal that you can work on. No? And what would you like them to achieve, to be able to do self-care by themselves, take a daily bath, use deodorants, brush their teeth, and if they're girls, be able to do menstrual hygiene. Okay, so um, this is a way of teaching older kids and teens who are not yet adept at taking care of themselves. So the tasks are actually broken down. So you can teach them. You can teach your child step by step. You can paste this or paskill sa bathroom door so that, or on the bathroom, so that they can remember the steps. No, so this is a way of teaching how to shower. Now, for girls, this changing menstrual pads, no, or our pads actually is a 10-step process that most of us don't even think about. But it takes 10 steps to change a pad. It's walking into the bathroom, pulling down the underwear, removing the soiled one, throwing it away, wiping yourself, getting a new pad, throwing away the wrapper, sticking it sticky side down so it sticks to the panty, and then putting back your underwear, flushing the toilet, and washing your hands. So we don't think about this in steps, but we need to teach this step by step, no, until that adolescent is self-sufficient. And uh, this is important because if they're in school, you can't really depend on the teacher or whoever is around to help your adolescent. So please try to work on this. If it's not yet a skill that your adolescent has, it's something that you should work on. Okay, what are the other things? We said that adolescents like to be independent, no, and we want their decision-making skills to develop because that's important, and that's the last part of the brain that develops the prefrontal lobe. So self-care and household chores. I think Samantha mentioned household chores. It's very important. Why is it important? Number one, it gives them responsibility. It teaches them skills, life skills. It also makes them feel that they're contributing to the household, no? So it also enhances their self-esteem. They should not be exempted from the household chores. Of course, it has to be appropriate. Hindi naman siya pwede mag-igib ng tubig if the child has a congenital heart disease. So, but please involve the child in taking care of the household and himself. That is very important, and that really builds resilience. No, household chores lang siya, but it means a lot. Okay, and also provide. You want them to develop decision-making skills. So provide them with choices. So, as simple as teaching them or allowing them to make choices about what to wear. You can lay out three shirts, and then you just ask them which one she or he wants to wear. Kung adolescent na, you can go shopping and ask her with what shampoo to use, what toothpaste, what toothbrush, things like that. Doesn't seem like it's significant, but really teaches them micro skills in decision making. And you build on those skills. You start with simple skills, and then you build up later on, no? Because we want them to be able to make choices. So same things with what to watch on TV, or if you're eating out, what to order, and practice how to order and behave in that situation. Okay. Also provide opportunities for new experiences. We notice it's what usually happens is after they're out of school, the opportunities to socialize also shrinks, no? So they're just in the house, they don't have any kind of stimulation. So look for ways, be very intentional. I mean, look for a way so that your child has exposure to social events. Well, not now because we have the pandemic, but eventually when things ease up, please remember it is very important to create your circle of support, and the socialization skills of your child has to be developed, and they need actually warm relationships, no, friendships. That's really important in their lives, and this may be found in church groups or youth groups, or even just making sure that they have a play date with a cousin or their cousins, no, or mga neighborhood kids. Okay, this was mentioned extensively already, but as Dr. Alexis said, there are procedures that you need as children, babies, children. You have to continue the checkups until they're adolescents, young adults, and then older adults. No, remember they can have um, hypothyroidism, diabetes, and all that. So the only way to kind of check it or even prevent it is to have the checkups with the doctors. So what happens in a checkup? Just very quickly, you have the growth can be monitored, the weight, the height can be plotted in the chart that Dr. Estrada mentioned, so that they can determine whether the child is overweight or underweight. Immunizations, they should receive all the immunizations that are due for children and adolescents, no? And this is usually missed. So parents, please take note that there are immunizations that are needed as they become adolescents. You need Tdap, tetanus, diphtheria, cellular pertussis, HPV vaccine. You need MMR, varicella, if those haven't been given yet. No? As emphasized earlier, TSH or thyroid function tests are very important because of the role of thyroid hormone in all the functions, practically all the functions of our body. The hearing, annual, as Dr. Alexis mentioned, no, they're prone to hearing problems. Checking for the eyes, they're prone to cataracts. They can have heart problems because of obesity or a congenital problem. They could have neck instability, no, because of the bones in the neck may not be stable. They can have problems with sleeping, snoring, no, and bowel movements can always be a problem. Constipation is part of DS and also a sign of hypothyroidism. Don't forget to have a dental visit every 6 months. And there's a heart condition, please make sure that there's antibiotic prophylaxis before a dental procedure. No. It was already mentioned earlier about mental health and the emergence of depression. And I think it was Mr. Paradyang who mentioned that his daughter had depression in her, I think, early 20s or adolescent or early 20s. Now, they are, although they're cheerful, they're quite a joy to be with. They are also prone to depression, anxiety, obsessive compulsive behaviors, regression with decline in loss of cognitive and social skills. They can have chronic sleep difficulties, daytime sleepiness, fatigue, and mood-related problems. No, so the approach here is basically, and this was illustrated earlier. No, most of these, especially depression, is a response to something that happened, a stressor. In the case of Mr. Paradyang's daughter, it was triggered by the loss of the brother and the classmate who she left behind as she was promoted to the next level. So you have to understand, figure out, no? And this is how the literature actually describes children with Down syndrome. They are exquisitely sensitive to things like this, and you also have to be sensitive. I mean, you have to be also aware of how this will impact. No, it doesn't mean that they have a cognitive disability. They don't feel as intensely as anybody else. No, if somebody is lost, there's grief. Now, the other thing that you have to think about is could this be a health problem? And hypothyroidism actually, if you're hypothyroid, you also kind of mimic the symptoms of depression. No, it's like matamlay ka, you don't have energy, you can't concentrate, you just want to stay in bed, which is also the symptoms of DS. No, so you need to make sure that it's not hypothyroidism. So you need the checkup. No, you need that evaluation, and please seek help for evaluation and treatment. And there is treatment. It's a combination of psychotherapy and medication. Although I think there was a question about medication earlier. The usual approach is quite cautious, no? Low dose first, and it's titrated, and there's always feedback, and there's always a close follow-up with the psychiatrist. So if there are side effects, these should be reported to the psychiatrist so she can evaluate whether the dose needs to be adjusted or it needs to be there needs to be a change, or if the diagnosis was right in the first place. So it's important really to be in touch with a mental health specialist, a psychiatrist who is easy to contact and easy to deal with. Okay, so uh, adolescents with DS have to deal with a lot of problems. So they will be dealing and they'll be talking to a lot of health professionals. So it's good to have medical records and a health book and a portfolio. And I think I remember Dr. Alexis mentioning that they have a baby book, but I wonder if they have an adolescent health book, which may be helpful, not to track all the data, all the findings, all the recommendations or the laboratories that need to be done. No, there's a whole list. It's not it's quite complicated. It's kind of complex na checkup. So this will keep things in a compact. And if you need to see somebody, you need to go to the ER. Dalhin mo lang to. It has already some of the data. So what is it? It has parts for the adolescent actually to accomplish. So it says here for the teen to write more about health problems, and then the doctor will also put in whether ears were checked or were there any tests that were recommended. No, and then there's also a page that tracks the development of independent skills. So it says here washing. It says here tick if you need help with any of these things, and then write a little bit more about this. So these are the self help. These are the skills that I was mentioning earlier. No, washing, dressing, going to the toilet, drinking, eating, and so again, this could be a nice project. This could be something that you guys can work on. No, developing a health record book that will be useful since adolescents will be seeing multidisciplinary services. So it also helps track progress towards self-care. And it can also involve the adolescent. No, there's input from the adolescent. How as much as possible involve the adolescent, because that's really one of the things we want them to develop. No, the being involved in their healthcare as much as possible. Kung hindi verbal yung anak mo or hindi siya pwedeng sumulat, just handing over the book to the doctor is already enough participation for that child. Okay, so this is also a nice a resource from the Children's Hospital of Philadelphia. They have a Trisomy 21 program, and this is a readiness checklist. It's actually 2 pages, so there's personal care and other aspects, no? And it just lists down the things that hopefully your adolescent will be able to do by himself, no? So this is like setting the goal that we said. So if you don't have a goal, you can't possibly achieve it, no? Because you don't know where you're going. So this is setting the goal and just working towards it. So this is an important document for me, because it really kind of concretizes what you need to do with your adolescent. Okay, so during adolescence, I think I mentioned early on in the lecture is that there are different transitions, not only the physical changes, the emotional, the sexual changes, but also transitions in terms of school placement, which should be discussed by Archie, guardianship and long-term financial planning, which was initially touched on by Alexis and also Mr. Paradyang, no? Just making arrangements as to who will take care of your child if you're gone, so that so you can ensure really the safety and the future of your child. Places to live, not really a big issue in our country, because they usually live with us in families, but which family, which relative, that will be an issue that you need to also discuss, no? Working towards independence, we have been talking about this, that this is really one that aspect, no, from being dependent to independent is a transition that we want to accomplish sana by the end of adolescence, if possible. The other transition is really where to get healthcare. Remember, as those with DS age, they also develop certain diseases that pediatricians may not be able to handle. So that's a transition that needs to be done. And this is a definition of transition, which may be different from the definition of transition in DepEd. No, in healthcare transition, it's the transfer from the pediatric child to adult healthcare. So example from, for instance, Dr. Babu Estrada is a pediatric endocrinologist. A transition would be transition or transfer of care to an adult endocrinologist. No, now remember, it's a process. It's not a one-time event. You can't just tell your adolescent and the parents na, oh, doon ka na kay doctor who so and so kasi you're this age na. No, it should be planned, and the parents have to prepare, the adolescent have to be prepared, and even the doctors have to be prepared. Now, this is challenging both for adolescents with or without disability. Mahirap talaga to look for that doctor who can take care of that adolescent, no? Even for those without disability. And as I mentioned, it involves preparation because sometimes the family and the adolescent will not want to leave the pediatrician who's been taking care of that baby, of that adolescent since day one of life. The attachments and the emotional attachments of that of that pediatrician to the family can actually be a hindrance, no? So aside from preparation of the family, there should be coordination. You should have a pathway, no? A pathway, make linkages and coordination between the pediatric team and the adult doctors, no? Especially if you have lots of records, like 6 inches of records to endorse to your adult doctors. It has to be planned. Okay. Why do we need to transition when we're so comfortable with our pediatrician, like Dr. Alexis? It's a thing that you have to understand that the needs also evolve. No, and our training as pediatricians only goes this far. We can probably do a screening or probably spot the symptoms, but in terms of management of, for instance, hypertension or heart disease, that's really the area of internal medicine. Also, our training for mental health problems, which can be complicated in those with DS, is not part of our specialty. So that's why we need adult counterparts, no? And this has to be understood, and this eventual transition to adult services should be discussed early on, so that the parents and the adolescent will not be surprised or traumatized by the transfer. And of course, you have to look for doctors who are open and kind and willing to listen. No? Now, the first thing I'd like to talk in the next few slides, I'd like to talk about the PGH transition program for youth with developmental disability, or the YDD clinic. No, the first thing we needed to do was to establish the medical home. Ano ba yung home? Well, it's home. It's where you get the sustenance. No, it's where you get the comprehensive, continuous care that is needed by somebody with disability. And this care is delivered in a holistic manner. No, it addresses not only the developmental problems but also the medical problems, the educational problems, the needs, behavioral, social, educational needs of the family. So this is the home. First, establish the home. So usually, sa DepEd, it's the home is the DepEd people. No, they're the primary physicians. For instance, Dr. Alexis, in a way, is the medical home. She's the primary physician. Now, because of all the but Dr. Alexis cannot deliver all the services. Remember, there are multiple challenges. So there should be, aside from developmental pediatrics, we come in adolescent medicine physicians. The family medicine physicians are the doctors who take care of adults also. So they are the ones we hand over our patients when they are ready. Department of Psychiatry, as because mental health problems come up, no, and for the parents, and both the parents and the adolescent and the young adult really need support. UP Camp, this is for, we also have OTs and PTs in the team. And other specialty clinics, now we can refer to Dr. Estrada for endocrine problems, etc. So you see that this is a multidisciplinary, interprofessional team actually, no? And the whole idea is to deliver services on a one-stop shop style. That means when they go to us, when they go to this clinic, all the professionals, all the doctors, all the PTs, the OTs, the psychiatrists, the social worker are there already. No, we hold the clinic in a nice area in PGH, renovated with the efforts of Dr. Alexis. We have several rooms, and each room is occupied by one specialty, and the adolescent kind of just visits us. They don't have to go to any of the other parts of the hospital just to look for us. So this is the one-stop shop concept, which is almost ideal, no? Because they don't have to look, they don't get lost, they don't go back to PGH several times. And so these are the services, no? Developmental evaluation, we do a medical evaluation, we do immunize, we screen for mental health issues. We also do risk assessment. We do a bit of counseling for both the adolescent and the parent. And then we link them to services that they need. We also talk about transition program planning and parent and patient education. Okay, so just to kind of illustrate how it's done, no? So this is the ideal. Now, for instance, developmental pediatrician and the multidisciplinary team in that clinic already prepared the adolescent, medically stable siya, almost independent or independent in terms of self-care. So parang pwede na siyang pumunta, i-transfer na siya dito and the primary physician will be the family medicine physician who already knows the adolescent, and the adolescent already has met in the transition clinic, no? So this is the ideal. However, this doesn't happen all the time because this is not happening all the time. It happens in some adolescents. For some adolescents, it's not possible because they're not really, some of their developmental needs are not met. So this is what's happening, no? So this is still a medical home, and then although the adolescent is now a young adult, we send them out. This young adult is sent out to family med for medical interventions or assessments. And then the doctor from family med will also consult the developmental pediatrician for concerns. So there's a porous border, no? So back and forth. But eventually, we hope that it is really the wish and the purpose of the clinic that eventually this adolescent will be transitioned to the healthcare. Now, a big aspect, another part of the YDD clinic actually is patient education and parent training. And the patient education, as you already understand, is geared towards maximizing competence, no, and engendering independence. For the family, it's empowering the family to promote independence and understanding. Okay, so this was taken, I think, a couple of years ago. This was a big seminar we had. We had panelists, and we discussed transition issues, including guardianship. But I'd like to share an aspect that we always take care outside a seminar like this, which we always try to take care of during an encounter with an adolescent. No? And this is safety and abuse prevention. We should remember that even without a disability, actually sa Filipino children, 65% experience some kind of abuse. So it's twice as likely for those with disability and 4 to 10 times more likely for those with developmental disability. So this is something that we should always be on the lookout for. um, I think Samantha mentioned about not going, not not going or not entertaining strangers or something. So she was really taught well. Uh, what is important is that age appropriate sexuality education helps in preventing sexual abuse. No, and maybe this is uncomfortable to think about. Should we even talk to them about sex? But we should, because it puts them at a disadvantage if they don't know anything. And we should also understand that adolescents with Down syndrome are sexual beings. They have sexual feelings. No, if you go through the literature or even just surf the internet, you'll see um, Down syndrome couples, and there have been marriages between Down syndrome um, boys and girls. So it has really changed. Now, sexuality education is really complicated. And it's complicated for those without disability, and even more complicated and complex for those with disability. And I think you're familiar with all the challenges here. It's the attitudes, it's the discomfort with the topic. It's parents generally feel lost talking about sex, sexuality. And there's, in terms of materials, it's not readily available. I don't know, maybe there are, but it's quite difficult to look for materials for on sexuality education for kids with disability. By the way, even our typical adolescents and children are not getting any kind of structured, comprehensive sexuality education up to now, and that probably explains why we have so many early pregnancies and high rates of HIV. Okay, so these are the things we teach when they see us. No, very quickly, I just instruct my fellows to have a clear book and to teach these messages. No, my body is mine, and this is setting up rules about touching, and practice this rule until it becomes expectation for everybody. So the parents should practice this and say, ask permission, or at least may abiso naman if you want to give a hug or a kiss, especially if that your child is now an adolescent. No, um, this actually teaches them boundaries, and you allow them also to say no. It's a usual practice for parents to tell their child na, oh, go hug tita, or kiss uncle, or kiss doctora, or and I'll just say, I kind of just back off and shake hands, and I just to show the parent that should not be done. No, they don't know that doctor. If that's the first time they've met, it's not appropriate to hug somebody that you just met. So these are the things that we should teach them. No, teaching them about boundaries, and really that they can say no to this request of kissing and hugging, which can lead to something else. And we have to use appropriate names for private parts. No, so wag na yung flower or cookie or whatever cute names we give, because that's not helpful. I know it's not comfortable for us to call the genitals by the names in our language. It's very awkward. If it's not comfortable for you, just use the doctor names. No, use penis, use vagina. But at least that's something understandable. No, if somebody says, somebody touched my flower or touched my patutoy, that may not be taken seriously. But somebody touched my penis, somebody touched my vulva. That's going to elicit some alarm. No, okay. So teach appropriate names to the private parts. Second is to designate private parts of the body that cannot be touched. So generally, it's the areas covered by the swimsuit or the underwear. No, so it's the front and the puwet. For the girls, it's also the breast and the front and the puwet. But I also would I've seen illustrations that also the mouth should be considered private. Nobody should stick in anything there. No, and no one should touch their private area except for hygiene, but only up to a certain age. No, adolescents should not be touched by anybody when they're doing the hygiene. They should be able to do this on their own. No? And even us, a doctor should ask permission, and as much as possible have a chaperone when we examine their private parts. That is something that is important. Now, designate private and public places of the house. So private is the bathroom, and there are acceptable things you can do in the bathroom that you cannot do in a public place of the house, like the sala or the dining. You cannot scratch your genitals in the sala or the dining area. So teaching private and public places. Personal care. That's why it's really important to stress that they should be able to take care of go to the toilet on their own, because it reinforces that the toilet is a private place where I do a private act. And if there's somebody with them in the toilet, that's not appropriate. Okay, so a child who is independent in using the bathroom is less vulnerable because they won't need help. No, you have an adolescent who doesn't know how to change her pads, might be asking another classmate to be with her, and so that sets up something that could go awry. Okay, we're almost done. Just a very quick way of teaching children and adolescents. Just know, go, tell. These are simple phrases that remind children of what to do if someone tries to touch them in a way that makes them uncomfortable or even bullies them. No, so say no, get away, and tell an adult. And if you're an adult, if your child tells you that somebody tried to touch them, please believe them. No, that sometimes the reason why they don't disclose, it's because they don't think people will believe them, or they feel guilty, or they don't know how to feel about it. So all of these are really important and should be discussed with our children and adolescents to keep them safe. Now, another area that we need to be sure that our kids are safe are online. No? Now, for parents, please be careful about uploading pictures and personal data. Sometimes parents upload pictures. They want to solicit, for instance, donation, or just an innocent act of just putting up a picture of the pretty child. But be careful and make sure that your settings are just for friends and not for friends of friends or public, because those pictures can be modified and they can become child pornography data. No, so that can be. It has been shown that it can be harvested and it can be modified, and they'll come out pornographic. So please be careful about uploading pictures of your children. And needless to say, we need to supervise, monitor, and limit screen time. You should know what they're doing there. Don't allow them to just be surfing on their own, to be in a chat group. Please, you're exposing them to possible danger. And sometimes they don't recognize abuse. So you have to teach them when it is abusive. Okay. So a few more slides. And these are other ways of safety and abuse prevention. Actually, creating positive self-image and social relationships make them less vulnerable. No? Because if they don't get affection from you or the family, they will look for it in maybe a stranger or somebody they meet on the internet. No? But if they're sure that they're loved, they won't be like thirsty or hungry for affection that can be used by somebody who's grooming them for abuse. Please take pride in their accomplishments, large and small. No, this is the parent of this child who is such a great artist. No, and so please celebrate their talents also, and show them that they are appreciated in any way you can. You can post it in the internet, yung mga artwork nila. That's going to be safe. And of course, look for ways for them to find friends, create support, no? And this is the last slide. I think this was mentioned tangentially by all the speakers that you can't, it takes a village, no? And uh, when you have a child with disability, creating the circles of support is something really intentional. And you have to plan this because you, as Mr. Parajang mentioned, it's a roller coaster ride. It can be very difficult, and you need those circles of support. No, it's not only like the family, but supports from neighbors, from groups like Norphil and Help, and from the doctors, of course. But create layers of support, extra support, because it can be very challenging. No. And these circles of support are to share ideas, how to tackle problems, learn from each other, no? And helping also involving the young adult in this circle of support. Um, I haven't really tried this, but it sounds so logical, and I think we're doing it. We're doing it in an informal way, but this is just creating a circle of 3 to 10 people, maybe in a chat box, in a chat, Viber chat. And there's no formal process, but there's a website you can go to. But I think this is something really doable, no? That creating that circle of support that will really. There are times you will be discouraged, and I can imagine that those there are lots of times that you can be discouraged, and you need that extra support, also for your mental health, no, for the parents' mental health, aside, and also for the adolescents' mental health. Yeah, and this is the Trisomy 21 Toolkit from the Children's Hospital of Philadelphia, also a really good source of information and checklists. The checklists that I initially showed came from here. And this is my last slide. And in summary, I talked about transitions in adolescence, which are a lot. There's growth and development, there's puberty, there's psychosocial, emotional, cognitive development, there's healthcare transition, there's transition from dependence to independence, and school and employment. Then I talked about adolescent growth and development, how it is similar, no, in the physical aspect, similar to all typical adolescents. But emotional, social, and cognitive development may be a little delayed. That's why they need more support here, no, in terms of developing decision-making skills, making choices, making friends. And we need to make sure that we take care of them so that they grow up to be healthy adolescents and healthy adults, because they are prone to, accelerated yung aging nila. And so we want to develop healthy habits and to work with the medical team. Have that annual checkup, please. Don't miss it, because it's so important to have those thyroid function tests, the CBC, the immunizations. All of those are important, no? To make sure that they grow up to be healthy adults. And of course, we have to make sure that they are also mentally healthy. We are aware that mental health problems, even in typical adolescents, arise during this period. And we also should be aware that in terms of abuse, higher rates of abuse among those with developmental disability, but we can do something about it. And I mentioned ways of training your child, and of course, creating a safe space in your home and online. No, and at the last few slides talked about healthcare transition, which needs planning, coordination, preparation of the adolescent and the family, and creating links with the adult services. This is very challenging for those with disability, but we have started to do some. We have started a program. It's not perfect, but it is the only one in the country, and we see some aspects that are really something that should be developed, no, and sana replicated. Although, as Mr. Parajang mentioned earlier, most of the services are in Manila and the urban places. So I'm really optimistic that eventually this sort of services, if they can they want to copy what we're doing in PGH, I think we're really open to um, to help out and to describe to you and to give you information about what we're doing. And so this is my slide, and thank you. And again, I end with this slide of remembering Samantha, um, and just really being amazed um, at her humanity and her smarts, and really amazed at how Alexis was able to take care of her and how the parents persisted um, through the medical problems. And I think Alexis mentioned that she was with the family when the child was 11 days old. So I think even at the time, they were already thinking about the end. Having a child who is well adjusted and happy, and through that journey, they were really working towards that end. And so it's important for us to identify our goals and our ends, and to get all the support that we can from the community, from support groups, from the doctors. Thank you very much.
Okay. Thank you po, Dr. Emma. Okay, moving forward with our third topic for this afternoon. Our third speaker has obtained his Bachelor and Master of Occupational Therapy from the University of the Philippines, Manila, and the University of Queensland, Australia, respectively. Currently, he is an assistant professor at the Graduate School of the University of Santo Tomas, Manila, and is the founder of the Independent Living Learning Center, Manila, Cebu, and Davao. Academia Progresiva de Manila, the Reach Foundation Incorporated, and Project Teach organization that promote the wellness, development, and inclusion of youth with disabilities in the Philippines. For all his efforts and collaborative programs with the private and government organization, our third speaker has earned national and international awards. Okay, let us all welcome Professor Abelardo Apollo David Jr.
Hello, everyone. Good afternoon. Please call me Archie for short. Abelardo Apollo is just too long and complicated to remember. But first of all, good afternoon to all of you. And congratulations to the organizers, Health Learning Center, Norphil, DSAPI, and NAGA for organizing this wonderful seminar. It is an honor to be speaking alongside such reputable and respected speakers who I consider as role models and mentors. Hearing Sam and Mr. Paradiang speak was truly an inspiration. So thank you for this opportunity to share some of the work that the Independent Living Learning Center, the Academia Progresiva de Manila, and the Reach Foundation do to help our youth with Down syndrome transition from the school to the workplace. So allow me to share a PowerPoint that I have prepared for this afternoon. There, just to check, can you hear my voice and can you see my slides?
Yes, po.
All right, so thank you. So, all right, let me just provide some contexts and stats on the employment of adults with Down syndrome. This information was obtained from a national survey conducted in the United States by Cumin and Schonbrot in 2015. It says that 57% of the adults with Down syndrome actually are engaged in some paid employment. 26% were involved in volunteer work. 3% were self-employed, whereas 30% were unemployed. among the main factors that the unemployed individuals with Down syndrome identified for them being out of work are transportation issues and a lack of job skills training and coaching. So my takeaway from this slide basically is, given proper support and preparation, individuals with Down syndrome can certainly be productive. Also from the same study, we have learned that the most common industries of employment of adults with Down syndrome include food services, office work, cleaning work, grocery work, and also work in workshops and warehouses. I find this to be quite similar with our experience here in the Philippines based on the work settings that our graduates from our work training program eventually end up being employed. This is also one of the reasons why our job readiness program tend to give more focus on teaching skills that there seems to be demand for in the job market. In a study conducted in Italy by Bertoli, they identified that beyond 30 years old, the percentage of people with Down syndrome who demonstrate a decline in function increased sharply. So, we learned from our previous speakers, Dr. Alexis and Dr. Estrada, Dr. Lianto, explained that when a child with Down syndrome reaches a certain age, they tend to be more predisposed to manifesting associated issues. And apart from physiological reasons that lead to this, the study identified the individual's inactivity and generally sedentary lifestyle as among the factors that lead to the decline. So it's very important for us parents, teachers, therapists, and advocates to really encourage our kids to lead an active lifestyle. I know it's very hard to resist sometimes, snuggling with these adorable individuals on the couch, watch TV with them, but we really have to resist. And we have to start the habit of an active lifestyle early. All right. So, helping individuals with Down syndrome transition from school to work can never be too early. In fact, we advocate for the teaching of behaviors such as responsibility, problem solving, and independent skills like self-care as early as childhood. Sam emphasized that when she gave this very practical advice to parents that for their children to grow up to be independent, it would be helpful for the kids to be involved in chores as children. However, the formal transition planning should start not later than 14 years old. So transition education involves looking into the future beyond school and envisioning all the skills and preparations that will be needed to lead the most fulfilling life possible. And all the learning and education and training that our children have obtained from preschool to elementary, high school, and perhaps even from post-secondary education give them the arsenal of tools that would equip them for life. So in the next slides, I will be sharing the timelines proposed by Dr. Alan Goldberg from the Syracuse University. And I have highlighted some tasks and activities that I feel are particularly or can be particularly relevant for us here in the country. So as children, we can teach our students essential social skills and work behaviors such as discipline and responsibility from daily living tasks such as grooming and hygiene and household chores. And this was again reiterated and emphasized by Sam. When the kids reach 11 to 13 years old, we can formally introduce key concepts about the different occupations through maybe books, movies, and even bringing the child to the parents' work on certain occasions. This is the time also when engaging in volunteer and community work can be helpful to help our students and children be exposed to the different types of occupations. At 14 years old, the parents must participate in the transition planning team. So if there are parents watching, I would strongly advise you when the child reaches 14 or is turning 14 to call for a meeting with the school administrators and to start crafting a transition plan, which basically reflects goals that are pertinent to your child's eventual employment. The transition plan is a program that can actually be incorporated in the standard curriculum that your child is in. So I understand that there may be some students here who are in SPED programs, or perhaps others are mainstreamed in regular curriculum. So regardless, the child with Down syndrome must have a transition program that is crafted by the teachers, the parents, doctors, therapists, and let us not forget to include the most important voice in the room, which is the students. All right? At 16 to 17 years old, which is around junior high here in the Philippines, the student must have already experienced holding a part-time job in school or in the community. And his or her curriculum must have a vocational training component. Fortunately, in the new K-12 curriculum of the DepEd, vocational training is already included. However, the parents and all the members of the education team must closely look into the types of accommodations and modifications that the student might need in order to fully benefit from his or her secondary curriculum. In the education team at this stage in the student's education, it is advised to involve the adult education or post-secondary training providers. So even if, let's say, the student is still in high school, the team should already engage stakeholders for, let's say, post-secondary education in the planning process. At this point, the team, particularly the parents and the student, must already discuss and ideally decide how long the student will stay in school. In the United States, students are allowed to be in the school system at the age of 21. Here, the DepEd extends the ceiling period to another 4 years. That is why students technically, particularly those with disabilities, can stay in the public school system up until 25 years old. However, there are instances wherein schools still can afford to be accommodating hence allowing students beyond that age to stay within the school system. So again, by 16 to 17 years old, the families and the teachers should already decide how long they intend to keep the child or the student in school, taking into account his or her abilities, the let's say opportunities for employment in their community, the students' desires and aspirations, among many other things. And also, at this stage, the family must also already start planning for guardianship. This was already explained by Dr. Reyes in her talk. Ideally, when the student is 18 to, in the Philippines, 25 years old, when they're about to exit the school system, legal guardianship should have already been established. And a very practical tip that we can give parents and the students themselves is they can actually enroll the person or individual with Down syndrome in SSS, PhilHealth, and security, even at least initially on a voluntary basis if the student is not employed yet. So, so that when the child or when the student reaches his or her retirement age, or whenever, let's say, he or she gets ill, he or she can actually avail of privileges, benefits, even loans from these government programs. Also, at this point, the family should decide what they envision for their child after school. Also, of course, taking into account the individual's own aspirations. Do they want to pursue post-secondary education, or do they want to pursue employment after school? And in some cases, there are also families here in the Philippines who would rather focus on helping the student acquire more advanced independent living skills, particularly money management, advocacy skills, independent living at home, and also focus on the expansion of the students' leisure and recreation activities. So depending on the team's decision, they should take necessary steps such as finding suitable employment for the student, having the student participate or engage in job fairs, and also further assess his or her vocational interests and goals. You know, in a study conducted on the common interests of individuals with Down syndrome, unfortunately, what emerged was actually watching TV, which is a very sedentary leisure activity. So perhaps the students or the individuals might have not been given the opportunity to explore other activities. That's why they persist on such sedentary leisure activities. So in the next few slides, I would like to present some of the work that we do in the ILLC, and I will try my best to demonstrate how the aforementioned tasks and timelines have influenced some of our work. So the ILLC, or Independent Living Learning Center, was established in 2003. And from its initial campus in Manila, we have opened a school in Cebu and Davao in 2005 and 2019, respectively. From the 4 pioneer students that I worked with in 2005, we have had the opportunity to work with and be inspired by over 2,000 students already. And roughly 12% of these students have Down syndrome. So the school to work transition programs in ILLC start early through what we call our Modified Basic Education Program, or our MBE. So as early as kindergarten, in fact, 4 years old, the students are already immersed in a hybrid curriculum, if I may say. So this curriculum basically has academic components that are inspired by the DepEd's K-12, which focuses on competencies and topics that are most essential for eventual adult living, that are attainable given the students' abilities and aptitudes, and that are practical for independent living. This academic functional curriculum is coupled with a life skills curriculum that focuses on teaching self-help, co-management, social skills, and primary work behaviors. Students in the Modified Basic Education Program have the opportunity to earn credentials from the DepEd for preschool to elementary SPED diploma. In this program, the students also have the opportunity to learn alongside their typically developing peers through a mainstreaming program in collaboration with our sister school, the APDM, which I shall be introducing in a short while. So roughly estimating, we would say about 60% of the curriculum of students in the MBE is composed of practical academics, while the rest cover life skills training. When the student reaches 13 years old, the focus of instruction shifts to a more practical curriculum. This is through what we call our Transition Education Program, or the TEP, which has two tracks, the practical track and the academic track. If the team recommends that the student's curriculum should be enriched with more academic components because the student was deemed to be receptive to further academic instruction, the student's transition education program may be supplemented with what we call a functional basic ed program, or FBE, which could allow the student to continue earning credentials up to high school. So the FBE covers subjects that are typically included in the DepEd's K-12, like science, math, social studies, Filipino. However, we emphasize that this is a modified curriculum. We only choose the topics that are most essential for independent living and that the students can realistically achieve within the school year. Now, the students whose doctors, psychologists, therapists, and parents feel might not be as stimulable to academic instruction, or whose priority isn't really directed towards earning degree in high school, may take the practical track of the TEP. Now, students in both track may enroll in what we call the Job Readiness Program, which targets teaching work behaviors and life skills in actual but controlled work environments. I'll be happy to tell you more about the Job Readiness Program in the next slides. In addition to the JRP, students in the practical track may also benefit from the Total Communication Program, which basically enable students with limited speech to communicate through augmentative means, such as signing, maybe pictures, and we also have apps like ProLoco to help the student express his or her needs, thoughts, desires, protests, etc. So in this slide, you can see some of our students in the Transition Ed program learning practical life skills as basic as eating, toileting, bathing, dressing, to more advanced skills such as cooking, clothing management, budgeting, car washing, and higher life skills like knowing about their rights as individuals with disabilities, and self-advocacy. So Angelo, as you can see over here, is a young man with Down syndrome, and he really struggled in subtraction. However, he values his independence, and he wants to be able to purchase his items from their neighborhood grocery by himself. But he never had the courage to do so, feeling that he might feel embarrassed when the cashier realizes that he has difficulty computing for his change. So what we advised him was, it's all right for you to actually ask the cashier if you still have change, or since he's a very perceptive person, we taught him how to read the social cues of the cashier. If the cashier already has given him his receipt and says thank you, and as though she indicates that the transaction's completed, Angelo can simply smile and say thank you. So that is just an example of how we can teach our students to adapt and be independent despite whatever limitations they might have, particularly in the area of academics. Angelo also knows how to drive their family car. So I remember one day, many years ago, when we had a class on car washing. So I thought it would be good for the students also to learn how to vacuum the interior of the car. So I requested Angelo to try and move my car closer to the power source so they can plug the vacuum cleaner. You can just imagine how fast my heart was beating at that time. But thankfully, Angelo was able to move my car successfully and in one piece. So really, our students' skills shouldn't be underestimated, and we should give them the opportunity to exercise their abilities and to participate in our family and community engagements. So this is just to highlight the essential skills that should be addressed in transition plans according to the National Dissemination Center for Children, USA. Again, apart from the previous skills that I've mentioned, they said it's important for the individual to learn how to self-assess his strengths and his limitations. It's important for them to know about their rights as citizens and as PWDs. I think the Down Syndrome Association is doing such a great job in promoting awareness. That is why more and more families now are open to talking about Down syndrome, and they really inspire us when they openly talk to their children about their diagnosis and explain to them that it is just one facet of their being, and that there's nothing to be embarrassed or ashamed about it. As I get to interact with more adolescents and adults through the years, I feel that this conversation about the individual's diagnosis is a crucial one to be had. It's funny how some parents feel uncomfortable bringing the topic up to their children when, in fact, whenever they have consultations with their doctors, their psychologists, with their therapists, and they openly discuss about the child's condition, diagnosis, limitations, the student is just in the room. So the student might actually be more aware of what's happening than we realize. So we just have to openly include them in the conversation for them to be able to have a better chance of eventually becoming effective self-advocates. A while ago, I already mentioned about the FBE, which is a supplemental program to the TEP that would allow selected students the opportunity to earn credentials for a degree in high school. The emphasis is placed on helping the students and the family integrate academic instruction into practical situations through home instructions. You know, in school, at the end of the day, the students in the FBE are given a weekly list of talking points. And these talking points are posted on the family's fridge or anywhere where it can be visibly seen by the members of the household. So if among the topics include, for example, the digestive system for science, and let's say the cities of Metro Manila for social studies, the student would notice that the different members of the household would tend to incorporate those talking points in their day-to-day conversations with the child. So for example, Lola might say, "Oh, Apo, I need to go to the dentist to get my teeth or dentures fixed so I could chew my food and be able to digest it better." And then probably Ate might say, "Oh, my tummy hurts. I think I might have had indigestion." And mommy, who's in the kitchen, would be saying, "We're going to have green leafy vegetables for dinner, which is good for our intestines." And, that's a very practical way of enriching the curriculum, applying it in the students' day-to-day life, and also, more importantly, involving the family. So ILC recently launched its senior high school SPED program, which offers a vocational track, home economics strand. And we chose this primarily because from our initial investigation within the school on the common interests and aptitudes of the students, this track seemed to be the most aligned and feasible. So among the specialized subjects in this program include cookery, front desk work, food and beverage, and handicrafts. Remember the common industries where people with Down syndrome are employed. I think graduating from this program would also give them a fairer chance of landing jobs in those industries. Of course, like in any other SPED program, the student has to have an IEP or an individualized education program. And this culminates with a practicum as a precursor for open or self-employment. One of our visions is for our graduates to have the option of manning their own treasure shop stall, as you can see here in this photo. The products of our students and other PWDs may be sold in this stall. So with this, we can also educate the wider community about the talents and abilities of PWD while giving our adult graduates a venue to help augment their income. So a while ago, I mentioned about the Total Com program for individuals who might have limitations with speech. And this is through the use of technology like apps, and we also use low-tech tools like picture cards and maybe also whiteboards for writing, etc. So for this to be truly effective, all the teachers in the school were trained and encouraged to use the augmentative communication systems as they engage with the student in school. The caregivers and the families of the students also went a similar training for them to be able to carry out the program at home. So the Job Readiness Program is accorded to our teen students for them to develop work behaviors and skills in actual but controlled environments. As you can see here, there are different units or departments within our school that actually serve as training spaces for our students, among which include our admin office, our canteen, the preschool department. There's also our library, housekeeping, etc. So our non-teaching staff certainly had to undergo training and orientation for them to be able to relate and work effectively with our JRP students. To offer the students opportunities for on-site training, we partnered with various establishments within our community that have accepted our students for OJT. Among these establishments are the organizations that are shown in this slide. So in the JRP, the students also get a monthly stipend. And this actually is a very effective way of also introducing and maybe reinforcing their money management skills and also punctuality, because they know that for every absence or times that they are tardy, they get a corresponding deduction from their stipend. So these are just some of our students at work. On the upper left photo, you see students doing processing work as though they're assembling microchips, no, for some IT firm, but they're actually repacking hot sauce packets for Greenwich. So as you can see, we have job readiness programs even for students who might have limited multitasking skills, limited academic aptitudes, and even those with, let's say, regulatory self-regulation issues. The diner offers catering services, and our students never fail to impress our clients with their attentiveness and charm, of course. Within school, we send out flyers to parents whose kids will be celebrating their birthday soon. So instead of ordering from the famous and mainstream fast food chains for the birthday celebrations, many actually just order from us. And we don't only deliver directly to the students' classroom, we actually have students also who have been trained how to facilitate simple games, parlor games, particularly for the preschool and early grade section. So that's another, I think, useful skill for our students to have. Now, the students who did their JRP or Job Readiness Program training outside the school also received very encouraging feedback from these companies' managers. They say that even their regular staff have learned to be more patient and also to communicate more effectively upon engaging with our students. It's very important for us to determine a good person and job fit to ensure a successful work placement. And this can be attained by carefully assessing the students' interests and aptitudes through tools such as these. Well, the Reading Free Vocational Interest Inventory is a perfect tool that we can use to determine the students' interests, even if they're nonverbal. So they basically just have to choose from a row of pictures the activity that they find most interesting, and it will tell us what industry they might be leaning most towards, at least as far as their interest is concerned. But of course, interest is just one of the things that we should look into. We should also assess their aptitudes. So the Oasis is one of those tools that could ultimately actually point us to the type of occupations that might be most appropriate for students considering their interests and aptitudes. Now, working isn't just about competitive employment. It's more allowing our students to engage in productive work, be it initially on a voluntary basis, maybe initially working in a more controlled workspace, such as sheltered workshops, might be more suitable for them. And there are instances wherein companies outsource work that can be done at home, where the individual can be more comfortable, safe, and easily supervised and assisted if needed by their primary caregivers. Now, these are just some photos of the work of our students. See how artistic and talented they are. Ralph is one of those, and he actually helped me in this PowerPoint presentation by supplying me with these very nice images. However, when I asked him to create some artwork for my PowerPoint, he was quick actually to discuss with me how much was my budget for his art pieces. And that actually also, of course, reassured me that, hey, this student is turning out to be a promising young entrepreneur artist. So how do we help students eventually land a job? As I mentioned, first we have to screen and evaluate the student, but not only that, we also have to look into the person's contexts, and this includes the family's expectations, what their values are, what are the available jobs within the student's community, and then from there, the teacher, therapist, or maybe psychologist can discuss the job options to the student and the family. Upon weighing all considerations, they will then decide which among the job options they'd like to pursue. Once this particular option has been identified, the teacher or therapist may arrange a meeting with the employer for an interview. In the interview, a job coach may be available alongside the student to maybe help the interviewer rephrase the questions if needed. And more importantly, during this meeting, the employer and the student and the job coach will be discussing the different terms of employment. Once they've agreed on that, the job coach will be preparing the workplace upon conducting a job assessment. He will be suggesting a job description for the student. And this is also when we can conduct sensitivity training for the different, for the employees, just for them to know what, for example, Down syndrome is, And even as basic as, the appropriate language to use when referring to the person being integrated in the workplace, and how they can work most effectively with the student. Simultaneously, that student will be undergoing simulated training in school based on the job description as recommended by the job coach. With adequate training obtained in school initially, the job coach may then arrange on-site training where the student will get to practice his skills in the actual workplace, initially supervised by the job coach. Now, the job coach role is also to transfer his supervisory skills to the office manager, who eventually will be serving as the student's job coach at work. The school will still be there for monitoring and just to ensure that the student's employment is sustained, because all throughout the student's employment, there may be changes, such as maybe the managers being rotated or companies relocating. That's when the coaches may come in again. So special thanks to these companies who have employed our graduates. Be certain to patronize them, pass by Shakey's, Overdose, South Star Drug, and you just might bump into J. Marie, Angela, Oscar, Arthur, and Vicky Lou, and the entire gang. So through the years, we have produced food checkers, bartenders, bouncers even, with, of course, the support of all the members of the team. Of course, being in school is not just about study and work. We have to promote a balanced lifestyle through leisure activities, sports, even proms. It's amazing how much behaved our students were when they were wearing their formal suits, gowns, and heels. So that made me wonder, should we actually make formal attire our official uniform, just to make it, I guess, easier for the teachers to keep their students seated and regulated during class? So ever since ILLC was established in 2003, I've always dreamt of giving the students the opportunity to learn alongside their typically developing peers. I've shared a little bit about that when I discussed the MBE, but this became a reality in 2015 or 14 when I established the Academia Progresiva de Manila, or APDM, which is a mainstream progressive school that adheres to inclusive education principles. The UNESCO acknowledges that students with Down syndrome and other disabilities who've had opportunities to learn in inclusive settings can actually be more prepared to adapt to the wider community. So the APDM caters to preschool and elementary students, being a young school, and it caters also to differently abled students through its mainstream and inclusion program. So the main difference between the two is in mainstreaming, the students' curriculum may be modified. The students in the inclusion program, however, can manage the regular curriculum, but need accommodations such as maybe extended time to fill out homeworks and seat works and quizzes, and maybe seating arrangements or use of tools, etc. But the curriculum of the students in the inclusion program is essentially the same. Now, one of the core values that we espouse in APDM is respect for diversity and inclusion. And this is what led the APDM to lead the development of the diversity and inclusion modules for preschool to late elementary students, which are meant to help typically developing students learn about diversity and inclusion and respect for differences in terms of appearance, race, faith, gender, economic status, and of course, ability. So this Dimples consists of a manual and kits with lesson plans, tools for preschool up to grade 6. So this comes with customized storybooks, videos, to promote diversity and inclusion. And it was piloted in APDM, in a public school in Metro Manila, and private and public schools in Myanmar. They're designed to be developmentally appropriate, culturally appropriate to ASEAN, and they have relatable co-maturing characters. So one of the most beloved characters in the Dimples that we have created is actually Mr. Alonzo, who is a trusty grocery worker in Dimples. So again, the Dimples is meant to fill that gap of teaching typically developing students about diversity and inclusion of persons with disabilities specifically. So here's just to share a clip of one of the videos in the Dimples featuring Mr. Alonzo.
Oh, hi Dina. Can I help you with your groceries today?
Wow, Mr. Alonso, you're here. Thank you for helping us.
Look at Mr. Alonso. He's also different, like your brother. He's working. Even if he has Down syndrome, he could still be happy and be a helpful member of the community.
Let's talk about Down syndrome. Down syndrome is a genetic disorder resulting from an extra copy of chromosome 21. This normally causes mild to moderate intellectual disability. Down syndrome is not a disease and is not contagious. Some of the features of a person with Down syndrome include dysmorphic round face, epicantic folds, simian crease, upward slanting eyes, flat nasal bridge, and tongue protrusion. Here are your bags, Dina. Happy to see you today.
Thank you so much, Mr. Alonso.
He's lucky that his family and school helped him to get a job. I'm glad that more and more companies are employing different people like him.
That's right. Thank you, Ito. Now, with everyone's support, I think my brother can be so much.
There, so that's just a clip of one of the videos for grade 4 students. So the Dimples was presented in the INPAC, and we're very honored for it being recognized with this Perla Santos Research Award on its effectiveness study. That's me receiving the certificate from, of course, the INPAC president, Dr. Reyes. So in APDM, we have food fairs where the students can practice their entrepreneurial skills, and in ILC as well, we have similar activities. So now that we are confronted with COVID, we really have to transition very swiftly to distance learning. So the DepEd has identified internet connection, gadgets as among the limitations faced by students and teachers. That is why now the parents are accorded the option of learning through synchronous virtual programs and through asynchronous programs that are mainly offline. When the government says it's safe already, perhaps in school and blended learning can be offered to our students as well. I hope the parents have also heard about this TV and radio-based instruction being promoted by the DepEd. It might work, especially for families who might not have access to internet. So to prepare for the new norms, the school, ILC, and APDM prepared the learning continuity plan, which details all the curriculum changes, policies of the school, and this was communicated to the parents way ahead, like as early as April. The parents were given workshops on teaching, learning, and principles, knowing that they will be serving as primary learning facilitators at home. mindful that this setup might predispose our students to stress and anxiety, parents were also taught about the different red flags of mental health issues and interventions such as basic guidance and referral to support sources. To prepare them for online learning, the parents underwent training on the different learning management system. But before that, we had to interview them individually to determine what gadgets they were using at home, how their internet connection is, how adept the caregivers are with technology. And from there, we designed customized training programs that we rendered one-on-one to the parents and caregivers and students before classes started. Also, we had a trial class before we resumed classes in August. And just yesterday, we concluded our first monthly parent satisfaction survey now that we've approached our first quarter mark. So these are just some of the practices that we employed in APDM and ILLC that we hope parents will also find, parents and teachers might find useful. So I spoke about ILLC and APDM. These are non-stock, non-profit organizations, but they're private schools as well. So many wonder, what about students from poor communities who might not have the opportunity to avail schooling in private schools, even with socialized tuition? I think this is when the REACH Foundation comes in, and the REACH Foundation basically partners with local government units in setting up therapy and education community-based programs. One of the activities that the REACH Foundation is particularly proud of is its collaboration with the Division of Mandaluyong in standardizing its transition education programs. So it basically entailed streamlining the practices of the different public schools as well as other line agencies, such as the following. And of course, our partners from the private sector as well. So one of the programs that we introduced in Mandaluyong City is what we call the Kitchen Specials, which serves as a vocational training program for teens and adults with disabilities. And basically, Kitchen Specials allows the student to learn work behaviors and skills, and also to help augment their family's income. So their products are actually sold in the school canteen. So with this, we get to encourage our public school students to try healthier alternatives for their snack and merienda. All right, so the Project Teach, again, is a CBR program that we're happy to also share to local government units who might be interested in adapting it for their constituents. So these are some of the reference that I've used for this presentation. Thank you for your attention. And for those who would like to reach me, you may email me at archie.david@ilcphilippines.com. So thank you. That ends my presentation.
Okay, thank you po, Sir Archie, for the presentation. So for our final activity for this afternoon is, may I call on Mr. Luis Harder and Ma'am Tess of Norfield to help us with the question and answer portion.
Hello.
Hello po, ma'am.
Yes, siguro unahan na ko na. Teacher Archie.
Hi, ma'am. Hi.
May tanong sa iyo si actually from Dr. Emma. Sabi niya, Archie, how do you teach, ano to? Wala. Sorry. How do you teach teens to explain their condition?
Yeah, actually, Thank you. No, because many practitioners and even parents find it like an uneasy conversation to tackle with the students. Normally, we begin by just talking about our traits, our strengths, our limitations. We talk about our similarities and our differences. And our approach normally is student-centered and directed. So we basically ask them questions, and then more often than not, at least for our teens and adult students, the students demonstrate some degree of awareness about their condition. So we can ask them, for example, who do you go to for help? Let's say when you're not feeling well. Do you see doctors? Who are your doctors? Why do you see that doctor? And then some student might say already that, I have autism, I have Down syndrome. And then we start exploring the details about the condition. So there's really, the best approach, I think, is when we let the students determine the flow of the conversation. But of course, practitioners have to be guided by an outline in their mind of topics that need to be covered. So for us, we cover first the characteristics of the person who is diagnosed of a certain condition. Then we help the student become more comfortable using the term, let's say Down syndrome or autism, by using the term respectfully and also just casually ourselves. And then from there, we can also start talking about the limitations that they experience. We tell them also that there are other people who experience the same. There are organizations that are actually created to help support individuals like them. We talk about their rights and their privileges. The depth of discussion also would vary depending on the language and cognitive abilities of the child. For some students, yung conversation can be as basic as them knowing that they have a disability. What does that mean? That basically means that they have challenges doing certain things that are important to them, that they would like to do, and they probably would need help in. And doon papasok din po yung use nung pag-advocate nila for their rights, like falling in, let's say, in queues, public transportation, using the cards. So yeah, but the parents also have to be involved as well. Before we even bring up the topic to the students, we tell the parents first, and they have to be on board so that they wouldn't be like surprised when the student comes home and starts talking about his condition. At least prepared sila and on board. So those are just some of the practices that we do when talking about the student's diagnosis. Other questions?
Thank you, Teacher Archie. Isunod ko pa isa pang tanong para sa'yo. Unanimous to. Ang tanong nila, Teacher Archie, ang swerte ng mga batang may Down syndrome na nakapag-aral sa school mo at iba pang magaling na center. Paano naman ang mga nasa public schools? Paano kaya ang transition nila from school to work?
Yeah, so maganda pong tanong. In fact, yung pong Reach Foundation partners with local government units and the pertinent line agencies such as the DepEd sa strengthen ng transition programs. As far as transition programs in public schools are concerned, ang ginawa po namin initially was we sat down with the division superintendent, and bawat division po meron silang SPED coordinator. So it's important na on board po ang mga leaders, ang mayor sa adhikaing ito. Now, pagka nagkaroon na po ng agreement na ito ay isang project na mahalagang gampanin ng DepEd, sisimulan po na kakausapin yung mga teachers po natin, particularly yung mga SPED teachers sa public schools, para tanungin sila kung ano ba yung kanilang mga practices. And from that conversation, makikita po alin yung mga magaganda na ginagawa ng mga teachers na magandang i-retain at gagawa po ng isang standard na kumbaga protocols at saka curriculum and program na susundan ng iba't ibang mga SPED schools within the division. Kasi ang nangyayari po before, ang experience po ng mga bata are largely dependent on the, I guess, personality, the level of preparedness and experience of the teacher. Dapat po kasi ang ating transition program has to be standard across all schools within the division. In fact, within the DepEd itself. Isang magandang balita po, ang DepEd ay nag-release na naman ng kanyang transition modules. However, mahalaga po ang tinatawag na contextualization at individualization. So our SPED teachers have to really take into account the results of their assessments in determining which among the competencies covered in the transition module of the DepEd are most essential to be taught to their students for a particular grade level. So, dun sa DepEd, ang naging experience po before ay, ang isang classroom, halo-halo ang mga estudyante. Mayroong mga may mild intellectual disability, mayroong may sensory issues, may autism, iba-ibang age, and that is very challenging for the teachers to handle. So one practical method that we actually employed in Mandaluyong City that helped a lot, that I hope perhaps you can consider, is coming up with a centralized team composed of interdisciplinary professionals that actually screened all the students employed in the enrolled in the public school at nag-recommend ng appropriate na groupings. And we know that not all schools naman are adequately equipped with teachers, classrooms para ma-run nila iba't ibang klaseng SPED programs. So we recommended that certain schools within the division focus on, let's say, a particular SPED program. For example, ito, early intervention, itong school naman na ito sa pre-voc, itong school naman to sa vocational training. So yung mga estudyante from the different public schools were advised to, let's say, enroll in their school within the community that was tasked to offer the program that is most appropriate to their needs and goals. So merong challenges yan initially kasi yung mga ibang mga magulang, imbes na across the house ang school, napalipat siya 2 blocks away, magta-tricycle. But meron mga solusyon para po magawa natin ng paraan na maging mas homogeneous yung classes. So yung isa sa mga programs na inintroduce ay ito nga pong vocational training program na housed na sa isang public school. Like dito sa Mandaluyong, meron sa Pedro P. Cruz, meron sa Isaac Lopez Integrated School. And yung mga estudyante po dito, they are taught food preparation skills. Part of the income that the kitchen specials, that's the name of the vocational training program, earns is given to the students to help augment their income. And nakiusap sa mga public school canteen na bigyan po ng space yung mga products ng mga bata para mayroong pong steady na market. Kasi the students can only be kept active in cooking and preparing, in doing marketing, if mayroong demand. So win-win nga siya kasi the students get to practice their skills, they get to earn, the public school students get to have more options to sa canteen na healthy and delicious and affordable, and na-create ng awareness doon sa public school system na even persons with disabilities can actually be helpful and productive. So ang tawag na sa kanila ate kuya doon sa canteen. Now we partnered also with Mandaluyong Vocational Training Center at sila yung in charge na nagtiteach po ng mga higher vocational skills sa mga graduates from our public schools. And once they completed those vocational training from the MVTVC, yung Persons with Disabilities Office ng Mandaluyong City ang in charge naman doon sa work placement. So as you can see, Project Teach, that's the name of our CBR program, streamlined the existing programs and services of these line agencies para po walang redundancy, para maging mas efficient. So hindi kinakailangan even na mag-allocate ng napakalaking budget for Project Teach kasi there were already people within the local government who do work for persons with disabilities. Kailangan lang i-streamline para po maging mas efficient. Yung mga DevPed na importante po yung role sa diagnosis, we partnered with developmental pediatricians. Initially, yan po sina Dr. Reyes ang nag-endorse po sa amin kay Dr. Villadolid, Dr. Titi, sila yung nanguna. Ngayon, ang medical center, ang kanila pong mga fellows ay nagpupunta sa amin para mag-train. And then to augment the manpower, we also partnered with universities who send interns to us. So it's really about collaboration. So tignan po yung existing resources at mag-identify ng partners, gumawa ng mga plano, involve po yung decision makers dyan from the start. Like your division superintendent, yung mayor po, mag-advocate po tayo. And Naga City is here and is a sponsor of this webinar. So if you'd be interested to hear more about Project Teach, I'll be happy to share the model po to you.
Okay, thank you, Teacher Archie. Another question po from our FB Live. Directed po ito sa ating mga doctors. Ito po yung tanong niya mula po kay Ma'am Cristina Viray Fuentes. Are the services mentioned at PGH one-stop shop can also accommodate adult, like a 40-year-old with Down syndrome? Thank you po. Anybody po from our doctors? And Dr. Alexis.
Emma, do you want me to answer that?
Yes, please, Alexis.
Okay, so we at PGH, especially in developmental and behavioral pediatrics and adolescent medicine, we have actually come to terms with the idea that our patients are ageless. In other words, titingnan namin kahit na yung adult. Tinuturuan namin po kasi yung mga internists, tinuturuan din po namin yung mga psychiatrists. So, nagpa-partner po kami kasi alam namin na hindi naman po namin kaya lahat. Pero may mga paraan para siguro pagsama-sama kami. I think Emma mentioned that when we are in a group, I think we're stronger and we can actually put our heads together and our ideas together pretty well so we can address the issues of the adult. So the only limiting factor at the moment would be, syempre ang aming gamit po ay pambata. So yun ang sinasabi ko kay Emma din minsan na dapat yung aming lugar ay hindi dapat na nababagay sa maliit kasi nakikita po namin pati newborns at saka sa mga matatanda. So right now, the Developmental Behavioral Studies Unit actually has that. We have changed, we have modified, and we have actually a setup which allows us to see the range of ages. So we have actually appreciated that concern. Pero gusto namin lumaki kasi gusto namin lumawak pa yung aming yung services kasi hindi naman namin kaya lahat sa PGH. Ngayon nga kahit na may pandemic, marami pa rin tumatawag at saka medyo na rin kami napupuno na yung schedules uli namin. So hindi na sila natatakot masyado Pero kami natatakot kami kasi baka pag nagsama-sama sila, hindi ho pwedeng, baka maghawa-hawaan or hindi natin po alam. So, yun lang. I think, baka Emma, you have something else to say.
I was thinking kasi of the practical aspect of it, Alexis, is that definitely hindi siya ma-turf, hindi siya ma-triage sa atin kasi you're pedia, no? But, they can approach, and maybe the entry point for that 40-year-old is family medicine,
Yes.
which is really wonderful with a family approach. So they can access the PGH. Okay, so memorize natin yung hotline namin. It's 155-200. You can call and then you can register sa namin sa we have an online Okra. Okra. We have an online registration that's open, no? And so that could be an entry point, the family medicine. You can take care of them, and then they're free to consult the DevPed if there are any issues, no? But I think mainly the problems that will be involved here will be the ones that you mentioned, Alexis, no? The health problems.
Yeah.
And psychiatry is always open also for any of the mental health problems. So that's a nice thing about PGH because we have all the services available.
Okay po, thank you.
Dagdag ko lang po ang problema lang po namin siguro sa emergency room, kung sakasakali po silang pumasok doon. Kasi pati yun, that's manned by family med usually, and also an emergency medicine team. So, dito po, baka hindi po sila kaagad nakakatugon doon sa mga problema. Pero that's the reason why we are actually, si Emma, ako, at saka yung grupo namin sa Pedia, we try to reach out to our adult partners because we feel that our kids are getting bigger and they need more adult doctors to actually handle them. And even though the flesh is willing, the spirit is willing but the flesh is weak, for us, we find it a little hard to handle big individuals in our small cubicles. So hindi ginawa ang aming ang clinics namin for older individuals or adults. So yun medyo dun lang kami nahihirapan sa ngayon. Pero I think that hopefully when we reboot, sabi ko nga, we need to reboot and reorganize. I think that we will get more family physicians and also invite our internists to actually partner so that we can address the issues that are necessary for the adults.
Okay, thank you. Can I turn over now to Mr. Luis?
Yeah, thank you very much, Ma'am Tess. We have a question here, which I think I will also encounter soon, kasi 10-year-old na yung daughter ko. So we have a question to the doctors from Mrs. Lori Cruz. This is her question. Gusto kong itanong kung paano natin mahahandle yung mga crushes ng mga anak natin. At ano ang maganda gawin para malayo ang isip nila sa ganong subjects. Additional, dapat ba nating ilayo or should we tell them that it's natural lang sa tao yun? Yeah, please, doctors.
Si Archie yung na-assign ko dyan. We were already anticipating that question.
Dr. Yato, you predicted it accurately, so accurately. So, well, yeah, tama rin yung comment po ninyo, Sir Luis. Yung students or individuals, adolescents with Down syndrome also experience the same feelings and emotions that their peers do. Nagkaka-crush sila, nagkakaroon po sila even ng urges. And as health professionals and people who advocate for inclusive education, kami ang sinasabi po namin sa parents at mga pamilya po ng mga individuals with Down syndrome, itulungan natin sila kung paano nila maaring ma-experience yung life nila as fully as possible. Of course, while taking into account lahat po ng mga precautions at lahat ng mga safety guidelines. So pagdating po ng edad na 10 years old, adolescents, magtatanong ang bata tungkol sa kanyang crushes. And safe pa po yun kung crush ang kanyang mga tinatanong kasi madaling conversation pa yan. Pero paano pag sinabi na niyang, I want to have my own baby one day. One day, I'd like to get married. I will have a wife. Diligawan ko na itong magandang kapitbahay natin. So how do we have such conversations? Actually, 20 years ago, wala pa ako ganyang conversations with my students. Pero ngayon, naku po, parang nagninong na ako sa kasal. Would you believe that? Doktora, welcome me to the club. Welcome me to the club. So we had to, of course, involve the family in the process. Sa ngayon po sa Pilipinas kasi hindi pa necessarily in place lahat ng mga social service supports na maaring susubaybay sa mga individuals with Down syndrome na maaring mag-decide na magkapamilya, to live independently. So the family has to be involved. And yung lahat ng members ng team magde-decide po kung ano ang kanilang magiging stand tungkol sa usaping ito. Always involve then the person himself. Yung boses niya dapat ang pinakamalakas sa conversation. Huwag pong i-dismiss yung conversation sa crush. Okay lang, sabihin na it's natural for you to have a crush. Ask the child siguro, why is this person your crush? And then, pagka tinanong nyo sa kanya yun, how do you feel about your crush? At magsasabi siguro siya na siguro innocent na mga responses. But if the student already starts talking about gusto ko siyang maging boyfriend or asawa, magkakababy kami, that is a good window already for you to start the conversation. Kasi obviously, the student, the child, already knows something. So mas maganda po, nasa inyo namang galing, guided by the advice of your doctors and teachers, yung kanyang malalamang information, kesa doon sa sigurong iba na nasa paligid niya na hindi natin alam din kung ano ang kanilang mga intensyon at pakay. So kung nagtanong po siya, one day, gusto kong magka-baby. Okay, nako, ito na yung conversation. Dr. Aliato, pwede ko bang ibalik sa iyo? But ang aking pong experience sa mga estudyante po namin, magsisimula kami sa conversations about anatomy. So, ano ba yung parts ng anatomy natin that are relevant to reproduction? Banggit din yan sa lecture ni Dr. Aliato. And yung terminology, okay lang na gamitin po natin yung language na ginagamit para tukuyin yung mga parte ng katawan po na iyon. And then, pagka halimbawa pong nalaman na yung anatomy, pag-uusapan yung sex. Pwede pong pag-usapan yung sex. Sabihin po kung ayon halimbawa sa inyong values at culture, sinasabi ninyo yan at sa inyong faith na this is something that is engaged in by a couple. Okay, kung sa inyong paniniwala ng mga taong kasal, maaari niyong sabihin yon. At maaaring ginagawa nila yon dahil sila ay nais bumuo ng pamilya dahil maaari na dahil mag-asawa sila. And kailangan din pong talakayin. Ano din naman yung mga siguro repercussions ng pag-engage sa sex sa paraang hindi responsable. Hindi nyo tatakutin yung bata na, pag nag-sex ka, ikaw ay mabubuntis, ikaw ay magkakasakit, ikaw ay may suporta ba na ng iyong magiging anak? Kasi don't want sex to be a conversation na negative. So natural lang po kasi na aspeto yon sa aking pananaw ng buhay, pero sa nasabi ko nga, as therapists and educators, we would like to be also sensitive dun sa culture, dun sa values ng family. So if there is a teacher who wishes to engage and who feels that there's a need to engage in that conversation, then kausapin muna yung pamilya tungkol dun sa kanilang pananaw, dun sa kanilang values, and kung merong konting disalignment, do your best to educate the family with information, with facts, hanggang sa magkaroon po ng united na stand yung mga advocates para isang boses natin pag kinausap yung bata. Hindi po tayo nakukonfuse. Hindi po ang sinasabi ni Kuya, it's all right. Sinasabi ni Lola, nako, masusunog ka sa hell if you do that. Yung iba naman, iba ang sinasabi. So napaka-complex po niyang conversation to have, and sana po hindi po ako naka-offend ng anyone doon po sa aking pagbabahagi ng opinion.
Okay, dahil siguro isang tanong na lang before we close kasi po it's already almost 5 o'clock. Importante po yung tanong and may relation po to sa depression. Dr. Alexis, para po sa iyo yung tanong, how will depression be managed by parents aside from providing an antidepressant? And the second question din po is, my child is 22 years old and he suffered depression since December 2019. Unable to consult him to a psychiatrist, then and have a hard time reaching out this doctor. And sabi daw po to stop na daw the medication, but hindi na po nila ma-reach yung doctor na ito. And it seems that mag-start daw po sila all over again. Can you recommend me a doctor through online?
Okay, sagutin ko muna yung...
Pinakyaw ko na, Doc,
Sabi ko nga, nakita ko yung pangalan ko at saka yung depression. Medyo masalimuot na problema yan. Kasi ang depression po ay hindi lang nangyayari yan instantly. That means meron pong may mga naging siguro sitwasyon kung bakit nagkaroon ng depression. So, hindi ko rin po alam kung nasa edad kasi minsan po may mga pangangailangan ng bawat edad. Hindi natin matiyak kung yung pangangailangan na yon at hindi nabigay ang nag-cause ng depression. So, we need to know first everything around this child or adolescent for that matter, or adult kung matanda na po siya. Lagi po namin sinasabi na ito po kasi I'd like to make it very proactive rather than just answer a question on depression. I'd like to advise families to, kung nahihirapan po kayo dun sa mga problemang nakikita ninyo ngayon, sana po hindi dahil sa hindi tayo nagpapatingin. Kasi dapat po talaga may monitoring. Hindi naman po kasi ito ordinaryong problema. Hindi po ito parang tulad natin, tayo po ay nagpapamonitor din. Tulad natin, kailangan din po nila ng monitoring. Advice galing sa mga doktor kung anong gagawin nila, bawat edad. So kaya po merong surveillance, screening and surveillance. Napakahalaga po noon. Kasi pagkatapos po ng early intervention, parang period na yan eh. Yun po ang sadly na napansin namin at na may pinapakita si Emma. At saka na pag-usapan namin bilang mga doktor, hindi po namin kayang habulin ang panahon. Kailangan po talaga bantayan sila. So, kung ang problema natin ay siyempre pera, finances, meron po tayong solusyon. Yun lang, pag sa malalayong lugar, kailangan po natin tulungan. Ngayon nga maganda nga dahil sa teleconsultation, medyo naaabot namin yung kalayuan ng mga parte ng Pilipinas. Nagugulat kami, tumatawag pala galing Cagayan de Oro, galing sa iba't ibang parte ng bansa na hindi natin nakakausap in the usual manner. So, yun ang maganda. So, at least maaabot namin kayo through the teleconsultation. Pero paano naman po kasi yung magbibigay kung sakasakali ng gamot o ng paraan, ng programa, hahanapin din po namin kasi palagay ko hindi naman po I think there are services. Ang problema lang po because of the situation napipigilan tayong lumabas. So, yung pagpipigil sa paglabas ay isa sa mga mahirap na sitwasyon yun ngayon. So, kaya nga ang teleconsultation pag ginawa mo na maganda at very comprehensive will actually answer a lot of your questions. So, si Emma po, si Dr. Alianto po ang head ng telemedicine namin. So, pinag-uusapan namin ito matagal na nung nag-umpisa pa yung pandemic. Paano natin tutulungan yung napakalayo? Actually, sabi ko, ngayon mas matutulungan natin yung mas malalayo. Kasi makukontakt nila tayo through FB. Marami po sila pero nakakalungkot kasi gumagamit sila ng they have to pay for data. So kung maganda po sana ang ating connectivity, makakatulong tayo sa napakadaming mga nangangailangan. Pero babalik lang po ako sa depression. Ito po ay katulad ng binanggit ko, masalimuot kasi bago ka magbigay ng gamot, kailangan siguraduhin natin na ito ang kailangan niya. Kasi baka mamayang konti, palitan lang natin yung programa, bigyan lang natin sila ng gagawin, ayusin natin ang routine, at marami pang iba. You know, there are many reasons for an individual becoming depressed. And is it really depression? That's the question. Baka hindi depression. Baka dahil ano lang po siya, wala lang po kasi na lockdown, so wala yung mga kaibigan niya, nahiwalay siya, matagal siya nasa loob ng bahay, hindi siya masyadong pinapansin. So there are so many reasons. Or if you want to make it even more serious, baka may ibang problema. So it's so important to connect, and I agree, connect with the doctor so that we will be able to evaluate completely, fully. Siyempre, hindi po gold standard ang teleconsultation. Ang gold standard po ay face-to-face. Ibig sabihin, kailangan harapan. Pero ang teleconsultation will already give us an idea. Malaking bagay po yon dahil lalo na po doon sa mga matatagal na hindi mo nakita, like parang ang tagal ko na ho kayo hindi nakita. Hindi ko pwedeng hulaan kung ano nangyari sa inyo. Kailangan talaga matagal ang usapan. Minsan umaabot po ng oras. Kami po, nagbibigay po kami ng ganitong serbisyo sa ngayon sa PGH. In fact, parang bumalik na yung number of patients na nakikita namin. Lalo na sa DEV at saka sa adolescent din dahil sa teleconsultation lang. Pero in the next month, ito na pala, October, mag-face-to-face na po kami. Ngayon, ang problema lang ng face-to-face ay naka-PPE kayo, naka-PPE kami, baka hindi kami makilala ng pasyente. At baka matakot lalo na, oh my God, bakit sino yan? Parang naka-spaceman or bakit naka-maskara siya? Bakit? Maraming tanong. So, hindi po namin alam, dadahan-dahanin po namin, ititriage po namin yung teleconsultation. Titingnan namin kung gaano ka-importante at gaano kahalaga na makita tong batang to sa aming clinic ng face-to-face. Na pwede na namin actually gawin dahil gumawa na po kami ng mga mitigate, yung mga mitigating factors, inano na namin doon sa aming center, doon sa bagong, well, hindi naman bago, doon sa center namin, Developmental and Behavioral Studies unit namin, nakasama doon sila Emma. Inaayos na rin po namin ng mga clinic para maging safe para sa mga gustong pumunta at magpatingin. So, hindi ko po alam kung nasagot ko po yun, kasi ang tanong dito may sinabi, taga Dumaguete City pala sila. Medyo may kalayuan. Malapit-lapit na, tama ba, sa Cebu? Cebu, Emma? Or, yeah, Cebu, I think, marami po kaming, ang maganda lang po, we have already both developmental pediatricians and adolescent pediatricians in all parts of the Philippines. So, we hope to access them. Let us see what we can do for you. And, syempre, ito po ay commitment namin sa mga pasyente na nangangailangan kahit na po napakalayo. So I don't really know if I answered that question, but I think that gusto lang namin po malaman na may serbisyo po kami sa PGH. We have a teleconsultation service. We also have, and we'll start already, a face-to-face. Very limited, but actually we will be starting that as soon as we can. Pero may mga requirements po bago po mag-umpisa. So, yun lang po ang pinaplansya namin ngayon. Sinisigurado po namin na we can actually be prepared, hopefully before the year ends. But yun may nangangailangan na po ngayon, pwede ho sa teleconsultation. Wala akong bayad po yun sa teleconsultation. Si Emma po si Dr. Alianto po ang in charge ng aming teleconsultation. Na kasama po ako sa committee niya. So we help each other because we know that In our partnership, we really have to make certain that we have the complete picture, and a lot of people are willing to really assist us. In fact, lahat po nung aming equipment na protective are donated, including the HEPA filters, including po yung mga PPEs na susuotin namin. Ang dami pong nagbigay. So kami po ay natutuwa at kami po ay sana handa na rin po para harapin ang mga batang nangangailangan on a face-to-face level. Kasi right now, we are doing a lot of teleconsultation.
Thank you po. One last, Sir Luis po, it's your turn.
Thank you, Uli,
Thank you,
Ma'am Tess. Yeah, I'd like to address the question to to Dr. Alexis and to Dr. Emma. No? Base po dun sa mga experiences namin with parents with Down syndrome dito sa Metro Manila, even in the provinces po, alam po naman natin na merong kakulangan talaga sa mga developmental pediatricians. Ano po? And yan po yung usually na unang problema na kinakaharap ng mga magulang. Pangalawa po, kung sakali man pong meron dun sa kanilang lugar, o medyo malayo sa lugar, alam po natin na most of these countrymen are financially challenged po. Ngayon po, ang tanong ko po, maaari po pa natin pagalawin yung ating mga general pediatricians kasi commonly yun lang po yung mga available sa kanilang mga lugar. Minsan nga po parang wala pa yata. Na parang bigyan na lang natin ng checklist itong mga general pediatricians to guide the parents kung paano nila ano yung mga check-up na kailangan ng anak nila na may Down syndrome. Ngayon, kung hindi po pwede yun, paki-explain na lang po kung bakit hindi pwede. Kung pwede naman po, ano po yung assurance natin na tama yung ginagawa ng general pediatrician. Maraming salamat po.
Emma, ikaw sasagot? Ako naman. Okay, so
this is really your area.
Okay, so siguro itatahi ko po ang mga nakaharap sa aking mga tao ngayon. Itatahi ko yung kakayahan nila. Okay, so having said that, may programa na po kami na ginagawa para sa mga general pediatricians. Yung tawag namin second tier, matagal na po namin ginagawa yan. Tinuturuan na namin po sila mag-screening at saka mag-surveillance. Ibig sabihin, nakaka-pick up na po sila ng mga pasyente na kailangan nating makita na hindi pa namin wala pa kaming panahon para tingnan dahil sa haba ng listahan. Pero ngayon po actually, iba na usapan, medyo may panahon kami. So take advantage of that actually. So that's one. But I agree, kung nasa lugar ka na wala talagang developmental pediatrician, walang problema po na ang general pediatrician, kung sino man yan, na willing to actually collaborate with us, tutulungan po namin. Tulungan namin at with the teleconsultation, telemedicine that's available, they can already access us. Oo, matutulungan na po namin at mabibigyan na po namin sila ng paraan kahit na malayo. Kasi nga, ito ang kagandahan ito yung silver lining ng teleconsultation. You can always already access the services. So we can teach them what to do if the situation is going to be very difficult for the family to travel. For instance, napakalayo. Marami na po kaming ginagawang ganito po ngayon na naka-lockdown po tayo. Tinuturuan na po namin yung mga fellows in training. Nakakausap din nila po yung mga magulang at saka yung mga doktor na humahawak sa kanila at nabibigyan na po namin sila ng konting kaalaman at advice. Pero kung kailangan talagang iluwas, siguro paplanuhin po yon. We have to plan that, and planning that will probably mean approaching the LGUs. Ito po, there are many LGUs. Alam ni Archie, kaya itatahi ko kay Archie, there are many LGUs that are already very open. We have access to some of these LGUs, but Archie is in a better position kasi minsan tinatawagan ko siya, Archie, may kilala ka ba sa... Tapos sabi siguro niya, hindi ko naman kilala lahat, doktora, pero parang nandoon po si ganito. Okay, so nagtutulungan po kami so that the network is going to be very intertwined and integrated, because this is the time to set up a network. And if we had one before, we have to have a better one now, because this is when interconnectivity with the teleconsultation can allow us to really reach even the far-flung provinces, as long as they have equipment. So yan po ang ano. So the referral system will probably change in a way, but I think it will change for the better if our connectivity nga is good. And we're praying and hoping that our government will be able to address the situation as they promise. Now, kami naman din po nag-aabang din sa mga tumutulong. Meron pong tumutulong sa amin ngayon. Hindi po ito connected sa Down syndrome, but just to give you an example, we have a lot of medical students who are indigent, who are entering the College of Medicine, and who have no computers. So can you imagine, we have quite a number. Tinanong ko po sa dean, sabi niya, ang dami kailangan natin, Alexis, ng mga computers. Alam niyo ba, isang tawag lang doon sa mga kilala namin, nag-donate, pati kasama ang Globe. Kasi, sinabi ko na po Globe, kasi sila po yung kaagad nagbigay ng connectivity. What's a computer for if you do not have connectivity? So ito po, marami pong magagandang loob ngayon na nagbibigay, tumutulong, at kaya po kami ay natutuwa. At kung kaya namin gawin ito para sa mga doktor sa kinabukasan, sana po magawa din namin para dito sa mga pasyente namin nasa liblib na lugar. Hindi po, ito po, kaya nilang gawa ng paraan. Kasi nakakagulat po, kasi pag tumitingin kami sa mga videos nila sa FB, sa FB lang ginagamit nila, we are just very grateful that they allowed us in their homes, their humble homes, which actually is something that you need to maybe help them, maybe ayusin ng konti, sabihin natin, Mami, tanggalin muna natin ito ha, tapos yung pinagbigyan nila po kami pumasok sa kanilang mga bahay. So dahil doon, natutulungan namin sila. So sa daming unang nakita na namin, palagay ko magagawa pa rin ho namin pag-ayusin pa natin ang sistema. So it's the system that we need to work out. The individual problems will actually remain individual unless we put it together, It is going to be a combined effort. And I think that because people are now more inclined to really help each other, I hope, I'm looking at this very positively. And I hope that because of the, I would say, the humanity that is in front of us, that is in need, hindi lang dahil sa kanilang problema o kondisyon, dahil sa virus na nag-equalize ng lahat. Kahit na mayaman ka o hindi ka mayaman, pare-pareho tayong magkakaproblema dito sa sakit na to. So, sana po matulungan at gagawa po kami ng paraan. I think that ito po, nung nilapitan po ako ni Dr. De Los Reyes, naalala ko po yung mga unang araw namin, hindi po ako pwede makahindi kasi taga Bicol po ako, taga Naga. Sa kasamaang palad, ang tatay ko po ay gigising sa kanyang kasi sasabihin niya, hindi ka marunong mag-Bicol. Oo nga, pero naintindihan ko. So ito'y para sa ama ko na taga Bicol, taga Naga City. At yung sa mga nakikinig po sa Naga City ay kumusta po at magandang aldaw. Tama ba? Hindi ko na po alam kung tama yung sinabi ko. Okay.
All right. Thank you, Dr. Alexis. Now, the time is 5:17, so we will have to cut short our discussions dito. So, marami pang pwedeng puntahan yung ating diskusyon at pwede natin ituloy ito. You can contact each other, you can share ideas, you can create more seminars kasi dapat hindi dito yun magtapos. Pero for now, magtatapos na yung araw, kaya request na lang po for the panelists, Sir Herc, Teacher Kai from Health, Ma'am Kai from Northfield. Pabukas po ng camera ninyo for a group photo. So, Ma'am Tess, are you there po? Yon. So, Ma'am Jo, nandyan. Si Sir Herc na lang inaantay natin. Si Mama nandyan. So, Sir Herc? Hindi niya yata nakabukas. So, sige. Ayun. So, okay. Ma'am Adet is also there. So, one moment. We're waiting for Ma'am Adet. And we will screenshot pag hindi na gray. Well, first screenshot ngayon. 1, 2, 3, smile. Okay. Isa pa, kasi si Ma'am Adet nawawala pa, but we can't really wait. Ayun, there she is. So 1, 2, 3, smile. Thank you very much, everyone. And Teacher Kai, back to you as the MC. So maraming salamat po sa ating panelists. Palakpakan po natin virtually para maraming salamat. Maramdaman niyo yung aming pasalamat sa inyo. Thank you very much po.
Okay, so for the closing remark po, may we call on the Project Officer of Northfield Down Syndrome Program, Ms. Maricar Santino.
Hello, yun. So, thank you po. Since overtime na po tayo, ang gusto ko lang po talagang mag-close sa pasasalamat po. Maraming salamat syempre sa Initiative Health Learning Center at sa lahat po ng facilitators and speakers natin sa araw na ito. Ako po personally, maraming natutunan. And ganun din po, stay tuned po tayo sa Northfield Facebook page. May nakaabang po tayong webinar din on Down Syndrome and Behavior Management this October 15 and 16. Kasama po si Doc Alexis din and si Teacher Mai Sarongon. So yun lamang po, maraming salamat.